So my second time as a host. It's my honor to host this event. So I joined Esaote at 2017, and some of you may know me for past few years. I have a strong background from ultrasound. But when I first joined Esaote, and I'm very curious on the weight-bearing MRI, and when I come to India, Dr. Mahajan was the first key opinion leader that I met, and he been sharing with me how weight-bearing MRI can change the patient management. As most of us experience back pain, or maybe in the future will have back pain. And most of us know that the back pain only happens when we are standing. So this is something that very unique, special to really in the patient management, both in a diagnosis and also treatment plan. So really, I'm very glad that this time I managed to bring this meeting into India, which highly requested by Dr. Mahajan, being a founder of this society. So in order to have this meeting happen in India, so I would like to share my appreciation to our key opinion leaders who come all over the world, being here to support us. And I also want to share my appreciation to Dr. Mahajan's clinic, being a big supporter to us, send an invitation and reach out to as much as possible customers. And also my team, been working day and night to make this happen. I'm sure there will be more participants coming because this is a Sunday morning. Again, also appreciate most of our participants coming in a Sunday morning with us and spend a day with us. I think this is going to be a great event. And this is a great opportunity for all of us, get very close to our key opinion leader and understand how weight-bearing MRI can support us from clinician point of view and patient management point of view. So without further delay, let's invite our very first speaker, Dr. Mahajan, to share his experience on weight-bearing MRI. Yeah, so stage is...
But thank you for being here. We've been, I'll use this. We've been using weight-bearing MRI since 2011 in this city, and last year we purchased our. I'll try giving a bird's overview into the use in various parts of the body and how it has actually made a difference in diagnosis and hence to treatment. But before I do that, let me take you back to 2011 when, we had a meeting organized by Esaote in Florence, and over dinner at the Grand Hotel Baglioni, which is the best hotel of Florence, there were some of us and we decided to form a weight-bearing imaging society. As you can see, we asked for the menu card, and this was written on the back of the menu card, and 11 of us, including Professor Monetti, who's actually one of the most prominent radiologists of Italy. He looks after the Ferrari team. Any little problem and they land up at his door. And so what did we say? We hereby agree to the formation of Weight-Bearing Magnetic Resonance International Society. Of course, the name has undergone a slight modification since then. As founding members on this, the 14th day of May 2011. So there are great members. And there you see Professor Monetti, that's me, saying something. And this is the same document being projected on the screen. Oh, you can't see my pointer. Okay, it doesn't matter. So weight-bearing MRI, and how is it important? We know that conventional static MRI provides excellent details of anatomy and pathology of spine, joints, soft tissues. However, it lacks and may be limited in cases where pain is position dependent. And that is what happens generally in the spine, in the joints, especially the hip, knee, and ankle. Thereby limiting information, and it really creates in vivo, thus helping in understanding the natural motion behavior of joints. Several methods we've used in the past for evaluation of joint mechanics, cadaveric studies, external measurements of limb movement by motion capture methods, attaching optical markers, intracortically fluoroscopy, which has been predominantly used by brain radio information, and of course, in most of these, there is radiation. Weight-bearing MRI was first described in 1997, so it's been 26 years, as a means to assess the morphological changes of tissue surrounding the spinal canal, particularly the dural sac and nerve roots. And this is, we've already seen pictures of this. This is what we've been using for system. It's that is happening. Also, you know, actually have patients lie, with the head down position, and we've seen how the discs actually open up when you do that anti-gravity, so to say. So the advantages quite evident. It scores with non-invasive nature, nowhere near as good as physiological gravitational loading that happens normally when we stand up or sit. And of course, being an open MRI, there is no claustrophobia, and many patients come just for that. The current status, most extensive research has been done in the spine, knee, and ankle, with the application in hip and shoulder joints still in early phases, and it's incumbent upon all of us to actually do that and contribute to literature and contribute to improving the surgical outcomes in patients. The spine, we know that mechanics are more critical than signal, especially in degenerative disc disease, degenerative disease of the spine. We can also position-dependent symptoms of spinal canal stenosis. And there are multiple applications that are there in literature which actually highlight this fact. There is change ligamentum flavum, bulging in nearly one-third of spondylolisthesis Normal case, the lordosis increases, and this is what happens physiologically. You can also see that this is high quality images, diagnostic, high quality, even though we've fat patient, so much fat at the back, and yet you're getting high image quality. So when I first saw this machine in the year 2010-11, and I'd only dealt with high field MRI since 1987 when I started doing MRI, I was actually surprised at the quality of the images from a 0.25 Tesla scanner. And that's where I think the equipment design, the fact that, the mentions, these are fat. Asymmetrical case number no, technology. This was a patient of mine. She had been came back to India because she says when I lie down I'm fine. The moment I sit or stand, I have excruciating pain. She had undergone a high, but it showed reactivation. But as you can see in the supine MRI, there was no compression. Actually squishes out, goes into the spinal column, and causes marked compression of the nerve roots here, and also a forward buckling of the ligamentum flavum. And this was the reason. So, and yet another case where there is no lumbar canal stenosis that you can see in the supine position, but the moment you put them in the weight bearing position, see otherwise without normal intramural mobility throughout abduction, whereas this is a superior subluxation. Here you see superior subluxation for abduction. Now this is just not possible in a high-field MR, which is a tunnel, so you just can't get that. Abduction, again stress testing, here you can do with the examiner's finger, and this is the finger that you can see, and so this can all be done very nicely using dynamic imaging. Again, you can see stress testing in the AP direction by examiner's finger, showing decentering of the humeral head. This is at rest, and here you can see that there is subluxation, all shown very, very well. Hip again, weight bearing, cam and pincer morphologies are precursors to hip osteoarthrosis and important contributors to non-arthritic hip pain. And we need to pick this up early, otherwise if we don't take countermeasures, then this early osteoarthritis will just continue to progress. Weight-bearing MRI helps by identifying these clinically significant impingement morphologies, and there is significantly decreased anterior femoroacetabular clearance, which is seen on weight-bearing. You can do all measurements. Of course, this is how we do it. The acetabular rim seen here, the starting point of deviation from sphericity, all of these can be seen very well. These are healthy controls that you see on top, and this is cam and or pincer morphology. All these measurements can be made dynamically, and decreased anterior femoroacetabular clearance is seen in cam and pincer hips. Again, you can do this dynamically because the magnet is open from both sides. So you can do any amount of dynamic movement. Again, you know, what I would say Esaote has helped do is also go to the best radiologists, the best orthopedic surgeons, the best neurosurgeons, and do research, do see how it helps. And that's where we have over 200 publications. I think you have 3,500 of these MRIs installed worldwide, and of course not all of them are whole body MRIs, but we hope that as more and more of these machines get installed, we will have this paper concludes weight bearing MRI allowed to better identify PHI weight bearing since forever. And here you are able to see the conventional supine MRI may miss or underestimate findings, and this is where weight-bearing MRI of the knee helps. You can see this in the knee meniscus, where it is accurate. What you differentiate meniscal injuries, and this is where it helps, where you can see here there is posterior horn meniscal tear, which becomes more evident. This here you don't see that abnormality, but this becomes more evident on weight bearing. You can see that there's a tear here which is consistent with an unstable tear. Unstable tears need to be treated, need to undergo surgery. Now only some meniscal injuries are associated with surgery, stable tears can be managed conservatively, and this stability can be assessed by weight-bearing MRI. This is a normal meniscus where you see no change between supine and standing, whereas this is a case, again, stable, no change. Whereas here you can see this is an unstable tear where you can see MRI showing posterior shift of the is some. Again, another unstable tear, and these weight-bearing MRIs. And this can be done very, very easily, very quickly, high. You can see that these are very high quality images, and these are 3 millimeter, 6 millimeter images that we do. Weight-bearing showing increase in the degree of the extent of the tear on weight-bearing. Again, meniscal extrusion, to some extent it happens normally. If it is more, then you can know that this, look at this is supine, this is complete extrusion of this meniscus. Greater MME, and more intense knee pain, and if there's instability that's seen, then you may want to tackle it in a different way. Anterior cruciate ligament, again, many times on even high field MRI, we have a problem in knowing whether it is actually a complete tear or not. And this is where weight-bearing MRI helps. This is normal knee physiological changes which we see normally on weight-bearing. ACL deflection, you can see, and buckling of the posterior cruciate ligament, which one sees on weight-bearing. So this dynamicity can be useful even in those cases before actually going in. Uncovering of lateral meniscus tear. Can be seen on weight-bearing, which you may not see otherwise on a supine MRI. Again, multiple papers on this, a lot has been written. And in the patellofemoral joint, again, when there is subluxation, it is very, very useful. It can show dynamic measurements can be done. And again, the Insal-Salvati index, the lateral patellar displacement, lateral patellar angle, lateral patellar tilt, and the changes that occur can be seen very well. And this is not just technology for technology's sake. It is actually changing the way you treat the patient. This is a normal asymptomatic knee. You can see between supine and standing, there's no change. Whereas look at this. This is supine, and this is weight-bearing, and the angles change. The patella gets subluxed, again seen very nicely. And again, you can see this, and you can see again that it's high quality. That's supine, that's on weight-bearing, and there is a change that occurs. Again, yet another case, medial patellofemoral joint impingement, which is seen on weight-bearing, whereas you can see it looks absolutely normal on the supine MRI. Again, you can do dynamic MRI of the knee, and really it is incumbent upon us as radiologists and orthopedic surgeons to use this technology to the best effect for treating our patients. Ankle and foot, and weight-bearing in the ankle and foot, we've been doing weight-bearing x-rays, and there's been weight-bearing CT that's been available for about 6-7 years. But what MR does is also shows you, apart from bone and joints, It's able to show you soft tissues and overcome the limitations both of radiographs as well as of CT. And again, hindfoot kinematics, 50% weight bearing, 100% weight bearing, all of these can be seen. You can do dynamic imaging also of the ankle, see what changes occur. And again, measurements can be seen both can be done in normal and abnormal. So whatever you could do on weight bearing CT is now possible on weight bearing MR, and in addition you get soft tissue details. This is weight bearing and of course very thin sections, a lot of detail. And this is a patient with talonavicular chondropathy, where weight bearing shows increased spring ligament insufficiency with widening of the talonavicular joint, which you see on weight bearing. Again, measurements can be done, and this is posterior tendinopathy, tibialis posterior, and again you can do measurements and know what is going on. And this is a case from literature, high field MR done in the supine position. That is a CT scan which shows extra-articular talocalcaneal impingement. You see on weight bearing how the joint space reduction is occurring, and the same seen here. Look at this and look at that. So how much are we missing? One can see here. Again, one more case. This is the plantar fasciitis tear, which was overestimated actually on the supine MRI. Look at this, and this is on. Every technology has limitations, and there are limitations of weight-bearing MRI. It has lower imaging quality. Because many times I get asked this question, Doc Mahajan, is it as good as a 3 Tesla MRI? I say no, it's not as good. But it is of diagnostic quality, what I've seen. It's not just about making pretty pictures, but whether it's able to give a diagnosis. And in addition to supine MRI, it's able to give you physiological information, weight-bearing information. You're able to scan the patient in a position in which he develops pain. And that's something which we can't do on high-field MRI. It has longer scanning times, which can increase motion artifacts. This, to some extent, has been addressed in the newer machines with the newer coils. Imaging the patient in the position of symptomatology may lead to increased motion, leading to poor and decreased image quality. So we saw that when you put them in standing position, that's when they start having the pain and the cooperation reduces. That's why we prefer doing it at a 70-degree, 75-degree angle rather than this abnormal loop within the internal auditory canal. You can see the 7th and 8th nerves so very clearly. So in conclusion, I would like to say weight-bearing MRI can holistically assess the musculoskeletal system, acting as a one-stop shop for the evaluation of ligaments, muscles and bones, providing physiological and kinematic information about joint motion and relationships, and allowing preoperative load-bearing morphometrics. Thank you so very much for your attention.
Okay, no, you can stay here. It's not finished. So thanks a lot for your outstanding presentation. You really show the multiple possibility we have with weight-bearing MRI from the head to the toe. So that has been really amazing, not only the weight-bearing, but also the dynamic image. So now it's time to honor you and to thank you. So I kindly ask to Professor Monetti to come here. Please, Professor Monetti. Vieni qua, Giuseppe. And to Diraj and Rachel to manage this honor for you. Thanks. They Okay, just a picture. Picture, please. Okay, thanks again. Okay, so now let me introduce the next speaker. Is Professor Kai Villanova from Spain. He's director MRI of clinic in Girona, and is director School of European MRI.
Well, good morning. First of all, I'll have to thank you very much to Esaote for this kind invitation, Dr. Majani. It's a great pleasure to be here today, New Delhi, in this session, in this course on weight-bearing MRI. If I can have my slides, please. Okay. Just click, yeah. Excellent. And in the following minutes, as you can see from the title, is why we should have in our modern departments of radiology weight-bearing MRI. First of all, as you can see, this is where I come, from Girona. I guess few people from here know where is Girona. Girona is a small city, as you can realize, near Barcelona. Not a very well-known city, but if someone of you is quite fan from the gastronomy, you should know what is Girona, or why is known Girona. We have the privilege to have restaurant, top restaurant. It has been named several times #1 of the world. So you might have the opportunity, if you want to have a real experience meal, you will have in Girona. But today, the question that I will have to answer is why? Why a weight-bearing MRI in our modern department of radiology? So this is what I will try to answer in the following minutes. I will propose you this menu. This is different from Celler de Can Roca, but I hope that we'll have all these different menus for today. A brief introduction. Important to recognize and why this low field provides this significant imaging applications, the indications that this is something that we will be discussing the whole day today. But important nowadays, the cost effectiveness of this system. And this is very important, and I will try to analyze this because in our constraints economic systems, this is something that we have to be aware, very important. And finally, this is something that Dr. Majani has already, but diagnostic quality, because this is at the end the most important issue as a radiologist, as a clinical, to provide the best diagnostic for our patients. So this is something that we have to be aware. Is this system of good diagnostic quality? So this is something very important. And overall, I will conclude with these strengths, weaknesses, opportunities and threats of weight-bearing system. This is awards. This is like the Oscars of radiology in Europe. This is what it is called, the Eurominis, with all these different topics that implies of different hours that are provided to this device. What we since very few years, because it seemed that low field was dead few years ago, and now low field is low. Now this again. We have to December. Fine. We read every day in our workstations. But indeed, this view is not how we should read this sagittal view. Why? Because this sagittal view has been taken in this position. So, if we have to read really in this view, the patient has been upstanding. And then we can see that things might change from this to the real standing position. So this is how we are going to analyze, as it has already been said, and we are going to insist, because we see in a physiological examination position. And this is why it's going to change from the everyday supine position, unloaded position. We might miss diagnosis, and very important. Then we know, for instance, for the spine, that there is a complex forces that changes not only the muscular active dynamics, gravity, and this is why in this upstanding position there's going to be changes. And this is the system that provides this physiological analysis, the features that it can answer why the patient has symptoms. Otherwise we can miss the diagnosis. And we know if we change the diagnosis, we change the treatment. And this is the key. The diagnosis provides good treatment. So this is going to be very important. And this is the system that it provides to compare from the supine position to upright position, performing dynamic maneuvers, quantifying this changing morphology. We correlate the symptoms and the imaging, and this is why we induce the symptoms for the patients. We perform the stress position in order to analyze what are the changes. It has been shown that an average from 15 to 25 changes from this upright position. We're going to perform this in this G-scan MRI. As I have already said, all the coils dedicated for the different joints, the protocol with all the sequence available for any system, very important, water, fat signal. And this is how it's been performed. First of all, in the upright position, in this 85 degrees, and then to compare. The examination is being performed in the supine as a second phase. And this, also can include these physiological maneuvers, dynamic maneuvers, flexion, extension, lateral rotation. All these can be provided. I'm going to show just very fast because we are going to see a lot of specific lectures. So just also that this was indeed only the first experience after installing the first weight bearing that we performed more than 10 years ago, and we saw exactly the changes for bulging, even almost 10% from protrusion in this L5S1, reduced the neuroforamina, but a specific what it changed significantly was this spinal canal. And we quantify precisely, and the change from the supine position, reducing clearly from upright positions, especially the area, and the sagittal diameters, that it was clearly more significant in these specific locations. So this was a data that we, just when we started our examinations on the weight-bearing MRI, as you can see, more than 10 years ago. So this is why this clinical condition that the patient suffers pain, but the supine does not show any changes that could provide the pain. Either has facet joint osteoarthritis. But how can I prove that the patient after running feels pain? Well, then, it's just in this position that I can see the significant reducing of the spinal canal. A lot of different applications in the spine that we are going to see in the whole day today, but this is going to be very important in all these different causes that might provide pain to the spine. We have to prove why. And this is why we might have indirect signs, but we have to realize of the direct signs. What it changes the disalignment of the vertebral bodies that we cannot see in the supine position. And this is why then in the upright position we might see why, for instance, the patient suffers pain, but the MRI examination does not provide clearly change. And then we can see the changing of the diameter clearly from the supine to the upright. The key in this instability, why the pain is clearly related to this spinal stenosis, but this is only seen in the upright position. And of course, this is how we can prove and quantify with these different softwares that we can analyze, such as the Q-spine that today we can provide. And even the disc, so it's going to, or it might increase the protrusion whether there is the upright position, as it has been already in a lot of literature that it already provides that this upright position is going to change the different herniation. And the foramina, this is very important. The parasagittal views, not only the spinal canal, but also the obliteration of the foramina that is going to induce of the radicular pain that it provides more clearly, because here there is no obliteration in the supine and then obliteration on the neural foramina. So all these findings are going to be very important. And key in post-surgical examination, we know the risk that there is going to be in the adjacent segments to the surgery, that here there is no significant findings. We can evaluate what's the key of the clinical symptoms. As many examinations of MRI is supine, 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 just one examination, but in the proper condition is going to provide the key diagnosis. So 3 Tesla, very high quality does not mean high quality diagnosis. And this is something that has already been said, and I'm going to insist on this. This is not a matter of high quality images, this is a matter of high quality diagnosis. And we have to provide the system, the tool that it provides this diagnosis. And this is going to be very important. Again, post-surgical herniation that is not shown in the supine position. On the knee, there's going to be specific, I'm not going to go through, but just an overall that very important, the biomechanics, and the biomechanics it's in the standing position, and this is what might have. I'm not going to show because a lot of different examples that will be provided. Just this small feature that it's more clearly that is not shown in the supine position. Instability of ACL that has already been shown, but this is changing. This is good stability. This is not good stability of the LCA, and this is something that we have to be aware that it's going to be shown. Just for the ankle has been shown. Different impingements that it will be more clearly, especially in the upright position. For instance, on the fascia, that it's also clearly and in the upright position, very high signal intensity, that it can prove the fissure in the fascia in this fasciitis, and the instability from the anterior fascicle of the external ligament that it's just provided with this upright position. As I said also from my menu, that this is a very important issue, cost effectiveness. We know today what is the constraints, economic, and we have to provide in our management of our departments to provide these very important issues. Because what is the cost of the MRI? Well, the examination of MRI. Because in my department, the cost that I get paid from an MRI of the spine, it's the same if I'm performing 3 Tesla in a G-spine. So I receive the same, but I have to pay very different cost from the 3 Tesla to 0.25 Tesla. What is the energy power that consumes a 3 Tesla? What is the energy power that consumes 0.25? What is the maintenance? What is this cost that, as it has been recently shown, this is in 3 Tesla more than 50% cost that I have to pay annually. And the cost for the examination is the same. So then I have to manage. And this is going to be very important. And then, at the end, what is the final workup that I have to provide? The best diagnosis. The sufficient image that provides this diagnosis. So this is the important issue here. This is not matter to the very pretty image, as Dr. Majani has already said. So the quality is of the diagnosis. And this is something that radiologists has to be aware in order to implement the best cost effectiveness, high quality diagnosis. Because this is the same diagnosis. What? 50% lower cost. And this is the issue. This is gout from the patellar tendon. High quality contrast. So the diagnosis is the same. More pretty, but the diagnosis is the same. 50% reduced cost. This is the issue that as a radiologist we have to take in mind in our daily practice. What is the scientific evidence that this is a high quality diagnosis? You can realize this is more than 20 years ago, whether low field was not of the quality that we are having today. But this scientific is not from any radiologist, non-known radiologist. This is one of the main skeletal radiologists international. This is the former French president of the French Radiological Society and former president of the European Skeletal Radiological Society. This is more than 20 years ago, that already provide the diagnostic accuracy of ACL and meniscal tears from high field to low field in the lumbar spine. There is clear correlation, good agreement, either from these radicular compressions in the lumbar spine, low field, high field. The small joints, the hand and wrist, rheumatology. All the findings there is no change, high field, low field. And the knee. Post-surgical analysis of the meniscal recurrence tears. So the evidence is clear. Scientific diagnosis can be provided as accurate, high field, low field. And this is going to be key. So in overall, we have a lot of strengths of this low field weight-bearing system. Easy to install, patient maximum comfort, lower cost, reduce safety concerns, reduce distortions, improve hardware and software today than we were having previously, good quality image. We might have weakness. This is important. But we already know, of course, lower signal, lower field, some more duration that we're going to have. We don't have this functional information that advanced high field that can provide. This is important because in the big hospitals and where residents are trained, in most of the hospitals, there is no low field systems. And then when the radiologists finish the residency, they analyze the low field system and they say, I don't know how to ride this compact car. Remember? Because I'm driving always with the Ferraris. But you should know how to drive a Ferrari that you are used in your residency or with this Berliner. But you should know how to drive this manual car, this compact car. This is a good radiologist. No matter which equipment, you should diagnose efficiently. And this is very important. We might have reduced range of contrast. This system, G-scan system, a lot of opportunities can provide because we can have a dedicated areas for the department. Even it can be installed in certain clinical areas specific. This is a value-based medicine for sure. Either more interventional could be performed because this is an open system. And today, and this is something that Dr. Majani is yesterday when we very interesting that of course we need more research in these systems because much of the research is done in the high field. Artificial intelligence, everything in the high field. But then we have to translate. We can translate, and this is something that they are, or that it's very challenging. That these are tools that we are going to improve even if this artificial intelligence we can include in these systems, because we have to be aware of certain threats, as I have already been said. For radiologists, it seems that this is low quality because it's low field. And this is something that we have to be aware. And the innovations that we can provide with, as I have already said, from the high field, translate to this low field. And this is something that we have to push on this innovative to have also this innovation to the low field systems. So this is a challenge sometimes that if these systems can go outside, because these systems have to be included in the same department of radiology. So, in order to answer what was my initial question, for sure, as we have seen, almost all the MRIs of our demanding every day can be performed in a G-scan, much comfort for the patient, less claustrophobia, diagnostic quality, cost-effectiveness system, which can be installed with an optimal investment for sure. We can reduce because we can perform more examinations if we install more of these systems in our departments, and the added value of this weight bearing because we can evaluate in a physiological whether we can prove what is the symptoms for the patients in this dynamic examination, weight bearing, and the important more clinical correlation with the radiological information. And this is, at the end, our objective as radiologists, to improve the diagnosis of the patients. And just if I know it's a long way to Girona, but in 3 weeks we are having the tumor course, skeletal tumor course in Girona. But of course, if you cannot attend, you could have the opportunity to have a meal in the Celler of Can Roca. Otherwise, also This is online course also it will be, and also on demanding, so you can have registration either online, either on site in Girona, and if, anyhow, you will be welcome in Girona anytime, so just let me know. And thank you very much for your kind attention.
Okay, thank you very much, Professor Villanova. You can stay here, please, because it's also time to honor you. So thanks a lot to clarify the use of low field in radiology department, complementary to the other machine, and thanks to clarify the discrimination that we still have between high field and low field, because they are complementary system, and that is very well explained by Professor Villanova. So it's time to honor and kindly ask to Professor Majan to come here with us. And it's time to end Diraj and Rachel to honor and thanks Professor Kai Villanova. A special gift. Great. Special gift for the scientific community and a special thanks for your talk. Thanks a lot. Thanks. Okay, now I kindly ask to Professor Majan and Dr. Villanova if they can stay here with me, because I need now to interact with the audience. If you have any question about the presentation you have seen from Professor Majan and Dr. Villanova. Okay, we have one question. I think you can reply from the podium, okay?
Good morning. That was a really lovely presentation. I am Dr. Samir Grover from Batra Hospital, New Delhi. I am an orthopedic surgeon. My first question is to Dr. Mahajan. Sir, we have been routinely performing MRI lying down. What would you suggest from now on? We will send all our patients for a standing MRI, or what would be the indications where specifically we will be sending for a standing MRI? Are there any guidelines where you will say that no, this can go into the lying down position, this can go into the standing position?
Well, that's a very, very good question, and a question that's always asked. I would say when it's degenerative spinal disease, especially in the lumbar spine, even in the cervical spine, I would stick my neck out and say that when it's chronic degenerative spinal disease, then sending straight for a supine and upright MRI may be the way to go, especially now that we see that the image quality is very, very good. Where you suspect infection, tumors, and such like, where there's neurological deficit, and where there are symptoms that may be acute in nature, probably the way I would suggest is to first do a high field MR, and then based on what we find or do not find, then a weight bearing MRI can be complementary to the high field MRI. That is what I would say. Having said that, again I'll qualify that if we are suspecting a lesion in the spinal cord, then I would send for a high field MRI first rather than for a weight bearing MRI, because in that situation we may not be even looking at changing the diagnosis in the presence of neurological deficit. Professor Villanova, would you like to add?
Yeah, well, this is one of the key questions that most of our clinicians or they request when I should request this worldwide. And this is well, it is similar. So this type of patients that have performed a standard MRI and the suspicious, one of the main indications is for a spinal stenosis. So they suspect a spinal stenosis. The MRI don't show clear. This is for me, at least in the spine, because I'm not probably on the knee. There will be other, but for the spine, this is one of the key requests. Not specific findings on supine, but the suspicious for spinal stenosis. I mean, this is always a very important indication for weight bearing. A lot of findings that we might see. Yeah.
Sir, second question. What about the contrast enhancement? If you want a contrast enhancement, is it better for going in for a 3 Tesla or is better for?
Well, as I have already shown, 10 years ago, this was a problem. We didn't have a fat suppression. We know that contrast, of course, increases the contrast with this T1 fat suppression. Some years ago, we didn't have fat suppression on low field. We know this. Specific fat suppression. The fat suppression 10 years ago was a steer. We know a steer, we cannot provide the contrast and then have it. So, we have now sequence, Dixon sequence. This is impressive. So, T1, Dixon. We perform T1, and as I have already said and shown, this T1 with Dixon, you suppress the fat and you have the contrast. So, as the image I have provided, this is why, you know, you were going to ask, but the answer was there. The image. Very high quality T1 fat suppression, because this is the sequence key after contrast. 10 years ago, I could not answer that we have quality to perform contrast. Today, no problem, and the best quality of contrast in this system. Yes.
And the last question, sir.
That is also useful in the brain. You know, brain also we do fat suppressed T1 post contrast, and of course in the spine musculoskeletal system, you know, T1 suppression. Previously we could not suppress the fat on T1, which is now standard and very high resolution.
So could you tell us a little bit more about the Q spine?
Q spine, you want to take that?
Well, from my side, it's very recent that I have the installed, so I don't have the but probably
Professor Majanes, and we will have also specific presentation with Dr. Bruno.
Is technology which automatically, semi-automatically, will be able to segment each and will be able to give you 3D representation, so you can do morphometry automatically. It will be able to give you the dimensions at all levels in the spine. It will be able to, hence you'll be able to compare one scan with the other, or supine with weight bearing. And also, like I showed, you know, it can give you a fly through within the spinal canal, so that you can actually measure. So it's making the radiologist's task much easier, and also giving you accurate measurements which the orthopedic surgeon can also see and, you know, based on the findings, take a decision. So it's enhancing our diagnostic capability.
Thank you very much for the wonderful talks, both of you. It was amazing. I have a few questions to Mahajan sir. As I was seeing through, there were good number of things which was eye-opening, like you shown the tonsillar, the posterior fossa assessment which was there. Now, my question is very novice. Say many of the patients of a grade 1, we don't end up operating. So by seeing an image like this, it is directly giving us a clue or it becomes notional to imagine that there may be a sagging and a dynamic block there in the fluid dynamics or at the obex, which is again directing you towards a surgery. That is what indirectly it means and opens a new altogether diagnosis towards surgery.
We need to do much more work on this.
Yeah, yeah.
Currently, what we've done was in normal healthy volunteers, but in those where there's hydrocephalus, there's grade 1 tonsillar herniation, we will have to actually go ahead, do a body of work to see in the upright position, is it herniating more? Is there a CSF obstruction that's happening? Is there, because many times we see that patients have this pinch cock mechanism where, they get headache after few minutes or hours of standing, and that's where the pressure in the brain is increasing. So this, I personally believe, can be a great tool in those specific category of patients in determining whether you do operate or not operate based on the information that we can get on upright scanning.
Yeah, it is good for the surgeons. Probably the surgical indications are increasing the way you presented. Thank you, sir.
Well, and more so in the spine. In the spine, we actually found about 39% increase in compression. And as Professor Villanova has said, lumbar canal stenosis, which, how can you operate if you cannot see it on MR? And with weight-bearing MR, you're able to see it. And ultimately, everything has to be taken in the clinical context. If the patient clinically has lumbar canal stenosis and the MR is normal, then that's the patient who should come straight away for a weight-bearing MR.
Yeah, by the way, I'm Dr. Ajay Krishnan, practicing spine surgeon at Ahmedabad. Just to add to few questions to Chief Villanova, you mentioned about the opportunities in your last slides as for intervention. How will it help? That is what you meant by adding that statement in your opportunities for the last slide which you were talking about. That is one. Second is you talked about fingerprinting. I'm very novice to these ideas. What was that fingerprinting you wanted to talk about in AI? I didn't understand that. So two questions.
Yes, related to intervention, well, this is very important because, for instance, a lot of intervention, for instance, in the spine, just as injection for the facet joints, for instance, we know that this is mostly done, for instance, on CT, but of course, soft tissues CTs are well depicted on MRI. And this is an open system that in real time it can even perform. There are some initial studies that performing interventional in real time in the same MRI, and this requires open system just and this is something that can be performed in the system. So interventional, it's an option to be performed in the MRI.
Yeah, I want just to add that we will have after lunch a presentation for Professor Manfred, that is an interventional radiologist, and will show you the use of G-scan on this specific application.
And then for the second question, AI, this is not only in the acquisition, that this is going to be very important, in the post-processing. So for the examination, we said that one of the weakness probably is the longer time from the scan. So AI can solve this. First, we can perform, we could perform with AI the same time examination with AI as high field. So this might not be in the future a problem. And then the software, it will provide even increase the quality with AI. So this is tools that, for instance, there is research already, and Dr. Mayani is even working on this, that this is for sure. AI will provide, we said, low field, lower quality. In some years, I'm sure, low field, high quality.
Yes.
So that's what AI will provide.
Yeah, yeah. And I can confirm you that Esaote is working, developing this through University of Amsterdam and also try the help of Professor Marjan team. Last question, because we are a little bit delay, and after we move for the coffee break. Last question.
Hi, my name is Dr. Abhishek Jain, and I am a guy somewhere away from spine. I am a foot and ankle surgeon. Good morning to both the faculty, esteemed faculty. Now, I see a lot of adult acquired foot, flat foot, and I do a lot of weight bearing MRI in Sir's center. My question is, in fact, I'm doing a study on high field MRI versus low field MRI versus my intraoperative finding. Where is the discrepancy? My question is, the clarity with which you showed the ATFL and AIFL ligament on your slides, I have never seen such clarity on the 0.25 Tesla standing MRI. So my compulsion is that I always have to write for a standing and supine MRI. So why don't I see that clarity on the MRI here on 0.25 Tesla MRI?
See, those images are also from a 0.25, from the Esaote. What Esaote is doing currently is, we do have a dedicated coil for supine ankle or foot imaging. But as yet, when one stands, the whole dynamics change. So for that, they are in the process of developing. So in the standing position, as yet, we are still doing what we call in India jugaad. We are using another coil and trying to image it. But Esaote is cognizant of this because, especially, I've told them that this MRI, even if people do only foot treatment, this MRI will sell just for foot itself, provided we are able to get that dedicated coil when one is standing. When you lie down, you can actually have the foot like this and the coil can come below it. But you can't do that when you're standing. You can't put pressure on the coil. So they are working on developing something which will come circumferentially. And then we'll be able to get that same high quality that we get in supine foot or ankle imaging on upright imaging as well. And that day is not far. Supine and upright also. That was upright also, but longer time given. Again, patient cooperation is very necessary. The moment you make them stand, they start having pain. So if someone is more cooperative, then you can give more time and get better quality images. Also, as Professor Villanova has said, now with AI coming in, even noisy images which are obtained very quickly, we'll be able to, make them of much higher quality in the processing itself. So a lot of work is going on. So from a 0.25, you'll get 1.5 Tesla kind of image. From 1.5, you can get 3 Tesla. And hopefully from a 3 Tesla, you can get a 7 Tesla-like image.
Okay, really the last question. And
Dr. Mahajan, I am Dr. Raj Bahadur from Chandigarh. We have the first machine in Chandigarh before the PJ could get it. My question to you, I was supposed to get the MRI of a very important person, they say the Chief Minister, and he was so obese that he could not be accommodated in that. So whether you have a change now in the system to accommodate an obese person? Second question, please. In the case of cervical spondylotic myelopathy, which we deal quite frequently with the degenerative spine, do you find the signal change better with the 3 Tesla vis-a-vis 0.25 Tesla?
Let me take the second question first, sir. Definitely a 3 Tesla or a 1.5 Tesla would show spinal cord signal changes much better than what we can see. I mean, there's no ambiguity in this statement. So if I'm suspecting myelopathy, and I alluded to that also, there's neurological deficit, I would want a high field MRI. And in case there is some incongruity maybe in the cervical spine, 1 out of 50 cases may you may need to do weight-bearing MRI. Coming to the first, they've increased, I think, by 2 centimeters the distance, and so the chief minister did come to us, and then we had to put him in a wide bore 3 Tesla because he wouldn't go into even a regular bore 3 Tesla. He was so obese. So this definitely is a constraint. But in cases where we have to scan the head or the cervical spine, where the abdomen, actually Indians tend to have abdominal obesity, there we can still do it. But if it's the lumbar spine or the dorsal spine, then that's a problem. But because that distance is lesser, they're able to provide high.
Okay, yes. Sorry, coffee break is on this side. The coffee break is on this side if you want to take some. Because now, if there is a coffee break, there is a lot of noise. I don't depend on you. We will check. So I was thinking if we can do the interview when they are presenting and I take, for example, one doctor came out, 1 minute of answer and is done.
It's sunlight, so it's
And it is also very, and I don't know about the lights, you have to tell
so
me.
it's too much of light.
Too much.
Yeah, so like the interview.
Or,
you have any black
or
shades?
maybe we can do now inside here.
Yeah, we can do here. That's
During
perfect. We can put 2 chairs on the table. You both can sit there and they can take the interview.
Yeah,
That would
please,
be much
please,
better.
let me know and we can do
So
that.
we can cover the logo as well
Yes.
and give in the back.
Yes, okay, okay. Allora, let me ask to Professor Kai Villanova. Kai, if we can do the interview now, is it good for you? Perfect. Okay. So, first one is Professor Kai Villanova. Okay.
Hello.
Professor Kai Villanova is available for the interview. I can.
Someone you put 2 chairs upstairs so they can
Yes,
sit
yes,
and they
yes.
can make themselves comfortable.
Ah, gliel'hai detto tu? Ok, io riseguo l'intervista un attimo, ok? Giulia ti sta seguendo per fare la connessione qua. Sorry. Okay, switch off.
slide sono quelli come avevi fatto vedere tu, no? Sono già numerate, c'ho già tutto in inglese, poi decidiamo il lancio, come gestire la cosa. Io, cioè, devo dire poche parole, io ho già il concetto, ovviamente però anch'io poche parole in inglese, quindi.
Meglio che le mie parole io di te, però. Se no non parlo.
India is Director and Chief Spine Surgeon, Malika Spine Center. Thanks, Dr. Babu. The floor
Thank
is
you.
yours.
At the outset, I would like to thank the International Society for keeping me in the program. And I think we were the initial few ones who bought this upright MRI in southern part of India, the new machine, so the Brio one. So I'm a spine surgeon. I'm not a radiologist. So this is in-house MRI in the hospital. We have an exclusive spine center. We operate only on spine and treat only spine. So we have 5 consultants that caters us so that we can have our own MRI. Then we discussed many things, which one to have. We already have a 1.5 Tesla MRI in our center, and then this will definitely add value to whatever we are doing. So I'm going to speak because the gross overview has been already given by Mahajan sir and then the speakers before me. I am going to give it in a perspective of a surgeon. So how I use this MRI and what we have been doing for the past 1 year with this MRI machine once we got it. So this, somebody was asking yesterday from the Esaote, how did you came to know about this Esaote? That was when COVID hit all of us. I was jobless, sitting at home and thinking what to do next and what investments were to do and what new technology is going to come. That's the time when we had all those things. And actually, we have a hospital and the building doesn't suit for an MRI. The new superconducting magnet MRI can't be fitted into the MRI because all the rooms were filled with the consultants. So this somehow doesn't require too much of a space to occupy, and then we don't need to change too much of infrastructure to get this MRI machine into the hospital. That was the one positive point which actually probed us to go into the details. And then I requested my wife and somehow convinced her and removed her consultation room and started the MRI in the consultation room. Now she is earning more than what she used to get a consultation fee in that MRI machine. So that's how we are into this thing. And also we have been, as a spine surgeon, I am quite interested in the research on MRI. We had some international publications and award-winning publications on MRI and some disc diffusion, some basic work which I already did on MRI. So this probed me into this one. So this we all know, whenever a patient comes to us with an MRI, supine MRI, the first thing we ask the patient is MRI is fine, but you get an X-ray. You get an X-ray in standing, in flexion, extension. Then we decide what is the source of pain. Even though MRI shows a little bit of bulge, we are not sure whether that is causing the pain. We always ask the patient to get a dynamic X-ray in standing and also in flexion extension. That will give us the idea of how much of instability is there and what is the source of pain. Whether that black disc which is seen on MRI is the only source of pain, there is something added onto the spine. So this upright MRI gives the advantage of combining both. It can also give you the added value of weight bearing, and also will let you know about the neural compressions, ligament of arm buckling or hypertrophy or thickening or some facet collapse, and how the disc space gets narrowed and it causes further compression. So that's how we got into this one. The basic point, and these two statements are very convincing to the patients also to get an MRI in standing. We tell the patient that their pain is on standing. When the patient, actually the spinal pain, radicular pain or claudication, all these pains will get subsided when the patient takes rest. The good old saying of treatment for back pain is take rest and sleep on the floor. So when they are sleeping on the floor or taking rest, so the pain obviously goes away. We don't need to have the rocket science to tell that. So the same thing, but we are operating on these patients. We are deciding whether to go for surgery or not, basing on the super MRIs. But the patient has symptoms only on weight bearing and loading and standing. So these 2 points actually put some more knowledge into the spine. So and this Esaote as that upright MRI will give you the possibility of checking the spine in all possible directions, and it also gives the value of addition. So even before acquiring this MRI and got exposed to this MRI, we have been searching for what is the best options to get a dynamic weight bearing MRI. We have few things like there is a what is called as a Dynavest is the external compression device which people used to attach to the shoulders and the foot end and then tighten and apply the compression so that you can have a simulation of standing. It's an external compression device which is MR compatible, which also can be used in a 1.5 Tesla or a superconducting magnet that will give a relatively same amount of compression on the discs, but that can't give you the changes of sagittal profile, the lordosis which happens, and exact body weight of the patient, and those things can't be seen. And the other two are the positional MRIs. We can make the patient standing and sitting, and the other one is the kinetic MRI where you can actually take flexion and extensions. But this Esaote will give you the advantage of standing, but you can't take lumbar spine in flexion and extension. There are few MRIs which you can also take flexion and extensions of the lumbar spine. Cervical we can take in the flexion and extension using this one. So you can understand the mobility and also the load and the body weight, what is it doing to the spine. And also most importantly, comfort to the patient is very good advantage what we have seen in the past 1 year. Actually, these two advantages. One is that claustrophobia is not there, and the second great advantage is no noise. The only noise what the patient gets is the air conditioned noise inside the room. Otherwise, it's completely no noise kind of an examination. These two actually are very convincing for the patient because we started this in Andhra in the two states for some time, and then people who have been waiting for 14 to 15 years to get an MRI, just afraid of going into the tunnel or gantry. There's one interesting patient who came for a low back pain. I checked all his joints from cervical to shoulders to knees to. So he's a very rich person. So he wanted to get everything done on an MRI because so comfortable just sitting and lying onto the gantry. That is one added advantage. And also this also gives us the potentiality of actually dynamically checking the kinetic movements of the spine. We can see how actually the spine moves in flexion and extension, the real time, the video clipping. So this puts a completely different perspective for a patient where we used to tell the patient, don't move while taking an MRI. If you move, you don't get an MRI. So, but here we are actually taking MRI, asking the patient to move and see what exactly happening while taking the MRI. So, while taking in the flexion and extension, the slow movements, and this machine has got a potential to get up to 40 seconds of continuous video recording in flexion and extension, and you can see how the joints are moving. And this also can be done for the knees in flexion and extension, in the dynamic capabilities of how the meniscus are moving, and also medial lateral instability for the knee joints, although the ligament collaterals are opening, and the ACL deficiencies and meniscus how it is opening, and then the tendo-Achilles movements and ankle movements. So this has got tremendous potential as a orthopedic surgeon for me to clearly look into. But here comes the big issue. But these indications have to be actually put forward by surgeons, not by the radiologist, because radiologist can take whatever you want to take, but you need to know what you want. So it becomes like a surgeon-dependent, surgeon-oriented, surgeon-directed MRI examination rather than asking for a diagnosis. This is not for a diagnosis. Diagnosis is clearly established just by taking a supine MRI, but actually what you want to see as a surgeon and what you want to operate and pick up as a surgeon. So you have to drive what you need to get out of MRI. And also these things like now the post-COVID era, we have seen enormous increase in avians. And these avians, somehow they behave differently compared to the regular avians of post-steroid-induced, alcohol-induced. And people say that few cases are actually rapidly worsening and few cases are not rapidly worsening. So we started examining these patients in supine and standing and see what happens that part, the vertebral, femoral head, if it is collapsing on weight bearing or not collapsing on weight bearing, and taking abduction and adduction scans and see how this head is moving. And also there are few osteotomies are now being proposed, rotational osteotomies, so that you change the weight bearing to anterior or posterior or medial lateral. So we can actually check whether you are going to actually recreate the weight bearing surface not onto the area where there is a depression. So these are the few advantages on these things, and also there are enormous research possibilities which we can do it with this MRI. It's only we need to have that idea of what we want to do. I'm happy to share that we have been, after we bought this MRI 1 year back, so we got 2 international awards from the Spine Switzerland research. One on effect of standing and disc nutrition. Other one is on selecting ideal candidates for indirect decompression. I just want to go into those 2 perspectives and then explain what we have been using in these patients. So this is what we have got Spine Switzerland Discover Innovation Award. This, if you are the spine surgeons, they can easily connect to this one. Now the trend of spine surgery is not to do open decompression, it's to do a indirect decompression. So indirect decompression, by what I mean is, this is the standard surgery where we just open the spine and take out the interspinous ligaments, do laminectomy and take off the ligamentum flavum and decompress the nerves and decompress the foramen and decompress the roots. So instead, if you can actually, if this is the situation, you can actually decompress the spine, or you can actually distract the anterior column in between the vertebral bodies. You can distract and decompress the spine. That's what we call it as a OLIF, that is oblique lumbar interbody fusion, without actually decompressing directly the nerve roots. Indirectly, we distract the anterior vertebral body so that ligamentum flavum stretches out and the foramens open up and the facets, they reduce into the natural posture. And patient gets relieved of spinal compression even without opening the spine. So that has a tremendous advantage of not opening the canal and post-operative problems of scarring and stenosis. But the issue with this one is we don't know which patient will get benefit with this one, and whether we can get actual amount of decompression is possible with this technique or not. So now what people are, surgeons, as surgeons, what we are trying to do is we do that oblique lumbar interbody fusion, and if the patient is happy, then he is happy. If not happy, we will go back and do a small posterior decompression. That's what is happening now. So there are few indications where you can say that you don't need to miss this patient, and ideal candidate selection can be done with just checking the severity of stenosis and axial cross-sectional area and facet effusions and vacuum sign. These are the few signs by which we can identify the ideal patient who can get benefited with this technology. But the problem with this one is all this information is brought when the patient is supine, supine-based MRI. So we hypothesized that if you can take a standing MRI and also take an MRI in supine and with traction, we can actually find out ideal candidate for decompression. So we had this done it on 20 patients, single level disc, what we are going to plan. So we took MRI in supine, standing, and also applied traction. This traction is similar to what we are going to see when the patient undergoes surgery. So in standing MRI is a standard protocol. We take the MRI in the fixed 90 degrees position and use this custom made traction, apply 50% of body weight to the pelvis, to the foot end, and another 15% to the head end, and apply traction and take MRI after that. And we compare this standing MRI stenosis and also after traction MRI stenosis. If you are able to see the good amount of decompression, we think that guided is ideal for surgery. And we operate on this patient and also take a post-operative MRI and check, correlate with the results. This is how it looks like. This, you can see these are like few nice MRIs. This patient, same patient taken in supine, you can see the disc prolapse, and if the patient stands up, this is the situation. So complete, almost near total obliteration of the cord. So we may think this patient is okay to get indirect decompression because still there is a canal available. If you distract this one, patient can come back to his symptoms get relieved. But if somebody sees this kind of MRI, he is a little worried whether this will open up or not, whether the patient will have a good relief of symptoms or not. So we subjected this patient to traction. Now we can see how much this opens up in the spine. So these axial sections, we can see compressions here, and this is on standing, almost total canal obliteration, and in traction, and again it opens up. another case where there is listhesis, where there is spondylolisthesis, how much it can get reduced by just applying traction. So this till now we are used to take flexion extension X-rays and standing X-rays. But if you are operating on this patient and going for a indirect decompression, so we have to take a traction X-ray maybe in the future. And also the standing MRI can show how much of compression is worsening of the listhesis happening at L4, L5, and then getting reduced after putting patient on traction, and see how much of the canal opens up. So this is the patient whom we have actually done this surgery. You can see this patient, how the stenosis is worsened when the patient is standing. We operated on the patient with indirect decompression by doing a OLIF procedure, and post-operatively see a nice opening up of the canal. So if this is a new one technique by pre-operatively evaluating which patients gets advantage. Our another interest is on basic disc biology, how the disc nutrients gets diffused into the spine. So we used to take serial post-contrast MRIs. This study we have done in 2003, and it has won the most prestigious Easels Prize in 2003 on a supine MRI. In the supine MRI, what we used to do is we used to give a contrast to the normal human volunteers, and then take regular MRIs at 10 minutes, 2 hours, 6 hours, 12 hours, and 24 hours, and check how the contrast is getting diffused into the disc. And this intensity, increase in intensity, can be measured with cursors, custom-made cursors, and the signal intensity can be checked, and we can plot a time intensity curve on these patients. So that's how it will also take in the axials and also check for the signal intensity variations with the time after the dye is getting infused into the discs. So these are the few things which we have studied on a this is too basic study, but ultimately what we are going to get is a time intensity curve with time. What happens is the gadolinium dye. What we give is a gadolinium. This is a paramagnetic dye which goes into the disc, and that can be measured as an increase in signal intensity from the base value. Pre-contrast value by post-contrast value will give you across the timing, so we will know how much it is diffusing into the body, how much is diffusing into the disc, and how much is diffusing into the annulus, and that is the pattern that we see. Now we wanted to do this in standing and supine. So that's what we proposed for grant, and this also won the startup grant by Evospine International. So we do the same study in the patient is supine, and we do the same study in the patient is standing. Because prolonged standing has a detrimental effect on disc nutrition is the one concept which is proposed. Another concept is if the patient is continuously moving, disc will get more nutrition. That is healthy for the disc. So nobody knows what happens, how the disc gets nutrition. So we use this gadolinium dye. The gadolinium has got the same molecular weight as glucose. So whatever gadolinium goes in, if the gadolinium is able to go inside the disc, the glucose also goes into the disc, and patients gets a very good nutrition for the disc. So we are little worried whether this 0.25 Tesla MRI can pick up this small increase in signal intensities by giving a contrast. So you can see this pre-contrast MRI and 2 hours post-contrast MRI, a nice bands which are parallel to the end plates you can pick up onto the MRI. This is in supine, the same thing in standing. So we are still evaluating the results. In supine we are able to get both the end plates getting enhanced equally at the same time, but in standing only the superior end plate is enhancing and inferior is still not enhancing. It is taking time to the inferior end plate to get the nutrition. So we are going to get the results of this one, but this is a possibility that we can study even the minute increase in signal intensities using this 0.25 Tesla, and also know the effects of weight bearing on these disc nutritions. So it also helps in a basic disc biology experiments as well. So other important point area where we use this MRI is in the cervical, because the cervical has two advantages. One is we can see the weight bearing, in the sense the head weight on the cervical spine. The axial loading can be checked, and also same time you can also check the flexion and extensions, what is really happening with the cervical spine. These are the few examples of a flexion MRI, how it looks. And the same patient, if you subject the patient to extension with the head weight on, you can see this much of compression. But these are usually rarely used to diagnose the disease, but the patient is ambiguous and there is no clinico-radiological correlation in the sense symptoms are out of proportion to the MRI, supine MRI, then we tend to get these things done to get the things. So other on whether we want to do anterior or posterior surgery. So there are the two situations where the patient has got two discs. Usually we do anterior. I think Ajay is here. Ajay, what do you want to do for the first case here? Anterior or posterior? First case and second case, what is your ideal choice of treatment? First we will do anterior procedure, 2 levels. Yeah, 2 levels. Second one? But posterior, you are sure that the patient requires. The second one, you may go for posterior. And first one, you going to go for anterior. Thank you. Thank you, Ajay. That's very important thing what he has showed up. This is the discussion which we have in a daily practice, whether to go for anterior, posterior. The 2 levels, anterior is better. For the multiple levels, posterior is better. But what if they say the same patient in standing and flexion and extension? So this is just the same patient when supine. And the second one is when he is sitting with head weight on. So this is a tremendous change in philosophy and tremendous change in thinking process. Raj Bahadur sir is also. So this is how much of the additional things keep on happening with this MRI. So if you have operated on these 2 discs, which we used to do now, patient will get relief, but there are some additional things which are missed out, and patient may come back with some additional problems or not fully recovered with the symptoms later. So the same thing, the same patient in supine, and just by sitting, you can see how much the canal gets compressed at levels which are not seen on supine MRI. And if you subject the patient to flexion, and you can see how much of you can see this retrolisthesis happening at 2 places. And then if you subject the same patient to extension, the stenosis gets further narrowed up. So they all look like 4 different patients. If you ask somebody to do procedure, they will suggest 4 different surgeries for the same patient if you take an MRI in different position. But if you want a good result for the patient, these things needs to be evaluated before. But you don't need to do it for every case whom we are going to get surgery. But we started checking these things when we find, like Ajay Krishnan said, we want to know whether the patient has got myelopathy or not. So if you have a location of the myelomalacia not corresponding to the level of compression in supine MRI, that suspects us that there's something else is happening somewhere else. So we tend to do these things, and then we'll find out so where the problem is happening. So this is how the sagittal sections also show different amount of compressions in these patients. So other area where we check these patients is in the weight bearing, when there is a mild little subtle collapse happening, and we want to check the patient the fracture heals up, patient still complains of some vague pains, and we take it in a standing and supine MRIs and compare the amounts. And this is another area where the patient has got adjacent segments. You can see this patient, this MRI looks in the flexion, and in the extension you can see there is a small disc which is getting prolapsed at the level below the fusion. The adjacent ML effects also can be checked very nicely with these patients. Other area where we keep doing these things is in the syringomelia, where you can see the syrinx whether it's getting extended or not in the things. I think this is a summary of what we do as a spine surgeon, and the last few slides got messed up in the transfer. So it has got a tremendous potential if you are actually looking into these areas. After 1 year of experience, I can say that when you have a clinico-radiological mismatch, where you are not sure about why this patient is having so much of pain, and also if the patient comes to you with L4-5 disc prolapse and MRI, and the symptoms are somewhere at L3, knee pain, somewhere in the groin, and we are not sure what is really the problem. How many number of standing X-rays or flexion extensions if you take, you may not be able to find the compression, but if you take an MRI in standing, and then that will show the adjacent things. But there is a caution in that even normal volunteers also, if you subject them for a standing MRI, there is a tendency for normal ligaments also to buckle. And that should not be taken as a case for getting a surgery. So any disc, if you subject the patient for a standing MRI, gets worsened. Any ligament hypertrophy will show increase in compression when the patient stands up and bears, and there is a weight bearing. And that's where the clinical judgment comes in. If the symptoms are correlating, then you can do that. And there is a caution also in this one is proposing unindicated surgeries. By showing that MRI, see what happens when you are standing, see what happens if you are sitting, and that may be a case for you to propose. But actually, this can be used to avoid unnecessary surgeries as well. In the sense that the patient gets multiple level of symptoms, the surgeon's tendency is, so patient is also had 2-3 disc prolapse and 3-4 disc, why not do that also? If you subject this patient to standing MRI, you can actually find out the exact source of compression and exact area where there is a compression, and you can avoid doing unnecessary surgeries on this patient. Thank you very much for your kind attention. That's our study.
Okay, thanks a lot, Dr. Babu. That's an important point of view also from the spine surgeon, how to use this machine, and the indication that the spine surgeon can provide to the radiologist in order to make in a proper way the examination, provide the information of the patients. And then the radiologist can provide images with important indication for the follow-up of the surgery. So this just confirms how this machine can really facilitate the communication between the radiologist and the clinician. So thanks a lot, Dr. Babu, for your excellent presentation.
Thank you very much.
Now I kindly ask you to stay here because it's time to honor you to
for
be
buying
here.
machine.
Yes.
For buying machine.
Yes. So okay. Okay, we can invite here Dr. Majan and Dr. Bahadur and Dr. Majan both here, thanks. And Rachel can, yes.
Somebody can take a picture of me.
Yes, sure. I ask. Yeah. Dr. Babu. Special gift for you. Yes. Yes. Thanks a lot again. Thanks a lot. Yes. Good. Thanks. You can go that side because it's too. Yes. Okay. So now let's move to the next talk. We have Dr. Federico Bruno from Italy. Neuroradiologist from Salvatore Hospital, University of L'Aquila.
Thank you, Giacomo, for your presentation. Sì?
Fantastico.
L'unica cosa è che non si vede.
Allora, se vuoi puoi usare questo, credo, fammi provare. Sì, va avanti, indietro e con questo fai il...
Okay,
scegli tu, avanti e indietro e con questo. Okay?
Thank you. Good morning, dear colleagues. First of all, I'd like to thank Esaote for inviting me, taking this lecture, and all the local organization for this. My talk today, I will share our experience, either clinically and research with Esaote weight-bearing MRI, and what we learned in these years in weight-bearing imaging. The collaboration of our institution in L'Aquila with Esaote dates back to the early 90s, soon after the introduction of the first MR scanners, and ArtoScan was the first dedicated system. We always believed together with Esaote in the role of a dedicated system for musculoskeletal MRI, and we featured several scientific publications to prove their validity. 2004 was the year of installation of G-Scan in L'Aquila, and we are still using nowadays. And last year, we also implemented our fleet with the latest Esaote low-field scanner, the Magnifico. And as I mentioned before, the great bulk of our work was made with the G-Scan, thanks to its unique characteristics of table thinking that we know, and to obtain dynamic imaging of several joints. So in these years, we built a growing experience, and we learned important added values that weight-bearing imaging brings in most MSK pathology, especially in knees and spine, but not only. And I'm going to show some of the main indication and the main settings where we had the most significant results. First of all, the knee. We learned that it's important to have a specific indication, specific clinical indication. And for knee, instability, pivot instability is one of these. We know that ACL injuries are often accompanied by postural corneal injuries, and the involvement of postural corneal injuries in ACL can strongly influence the outcome after surgical ACL reconstruction. So the detection and repair of this lesion is paramount importance for an optical outcome. So we evaluated the diagnostic capability of weight-bearing MRI in patients with posterolateral instability, and from the results show an increased sensitivity of weight-bearing imaging in depicting not only the direct signs of ACL rupture, but also indirect signs of posterolateral corner involvement, and arthroscopic confirm the cases in 89% of cases. So as you see, especially for anterior tibial translation and uncovered lateral meniscus, we have a higher sensitivity for diagnosis. These are some cases. This is an increase of the hyperbuckle of the lateral meniscus. The posteral corneal structure, especially the menisco popliteal fascicles, are intact and are well depicted also with the low field, and there are no changes under load. In this other case, instead, we can see an alteration of the posterolateral corner structure that is much more evident in the weight bearing for the with the uncovering of the lateral meniscus. Again, another case of PCL instability. Standard examination shows ACL rupture and is a dishomogeneous signal at the level of the posterolar corneal structure. And in weight-bearing position, there is a striding changes in the anterior translation of the tibia and definite alteration of the PCL structures. We presented also this result in the ACR, RSNA, and described in this paper where we reviewed the advantages and limitations of weight-bearing MRI. Another important indication is for meniscal instability, because it is evaluated only during arthroscopy. So the orthopedic surgeon decided for a conservative treatment or repair during arthroscopy. And we tried to evaluate if weight-bearing MRI could enhance the sensitivity of the diagnostic imaging for the stability of meniscal lesions. As you can see in the results, this is a grade 1 lesion, and in weight-bearing position, the morphology of the meniscus and the lesion is the same, and the lesion is classified as stable. This is another lesion, grade 2 lesion, that as you can see here in the weight-bearing position, there is an extension of the tear of the meniscus till the articular surface, and this was diagnosed as an unstable and confirmed by arthroscopy. Also grade lesion, case of stable grade 3 lesion meniscus, and another grade 3 lesion that show instability in upright position with a shift of the posterior meniscus. Coronal, also coronal pain was very important to show the extrusion of the meniscus under load. Not only for degenerative lesions, but also for traumatic lesions. And this is a case of a meniscocapsular separation that was pretty evident when the patient was upright. And also in this case, in which under load, we evaluated a flap of the meniscus that also in this case was confirmed by arthroscopy. Patellofemoral joint. The stability of patellofemoral joint is particularly useful when imaged under load because multiple biomechanical factors can influence the patellofemoral pain, and the kinematics of the patellofemoral joint can change with quadricep contractions, so during load. And upright MRI can allow a comprehensive evaluation to investigate the patellofemoral biomechanics. In this paper, we evaluated the sensitivity of a weight-bearing MRI in depicting the patellofemoral maltracking and instability. As you can see in the picture, we found higher sensitivity for several measurements under load, especially for lateral patellar displacement, but the most sensitive indication was the lateral patellar tilt, as you can see in this case. And under quadricep contraction, we also found the evidence of changes in the height of the patella, as you can see here, and the alteration of the angles. So, weight-bearing MRI is useful to evaluate the biomechanical stress under physiological load, makes evident the latent instability of some structure, increasing the sensitivity of the MRI. This leads to a more precise clinical indication to the orthopedic surgeon with a potential reduction of invasive procedures and medical costs. Of course, also for ankle and foot pathologies that are posture-dependent and load-dependent, weight-bearing MRI is very important. In our experience in this paper, we evaluated patients with overload pathologies of the coxapedis, and we found an increase of the alteration of the spring ligament and sinus tarsi pathology with weight-bearing scans. This is another case with the general signs at the level of the talonavicular joint, and under load we can appreciate a widening of the calcaneonavicular space suggested from spring ligament insufficiency. Another important case, a patient with rheumatoid arthritis with extensive synovitis at the level of the sinus tarsi, and what we see when we put the patient upright is a complete collapse of the spring ligament and the coxapedis with downward deviation of the head of the talus. That is also evident in coronal slices. We had also experiences with the imaging of the foot. In particular, we wanted to try to depict the MR imaging of changes during high heel wearings. So we used two orthopedic support to simulate a 5 centimeter and 12 centimeter here in the standard position, with the 5 centimeter here and with the 12 centimeter here. And as you can see from this picture, the main modification were on the coronal plane with a progressive increase of the angle between the first and the fifth metatarsal. Evident also in the axial plane with a concomitant progressive increase in the distance between the head of the first and the fifth metatarsal. And at the same time, a reduction of the transverse arch 8 at the level of the third metatarsal. On the sagittal plane, we can measure the metatarsal cover angle, and also it resulted in increases with higher yields. Of course, these are preliminary results. Above all, it's an anatomical study, but this can pose the base for a different approach to metatarsalgia patient. And now let's move to the imaging of the spine, as other speakers said, the added value lies in the fact that conventional MRI examination of the spine are performed in the supine rest position, and we know that in supine position the spine is subjected to only 25% of the load that we have in upright position. So this can result in negative findings, even in the presence of symptoms, or underestimation of pathological findings. We know other dynamic techniques such as X-ray, axial load techniques. Axial load techniques is used somewhere, but does not take account of the muscular activation and the forces caudocranial. So conceptually, the upright MRI is, of course, the modality of choice for MRI imaging that makes a truly functional study. In this article, we reviewed the state of the art of dynamic MRI of the spine, from anatomical evidence to pathological clinical pictures, and the modification of the spinal curvature are also important because they reflect muscular activation, and we noticed that in coronal plane we can also evaluate the muscular activation that we know that can be an important contributing factor to low back pain. After 10 years of experience with G-scan, we published this article reviewing lumbar MRI examination of more than 4,000 patients, and roughly dividing patients into positive patient with MRI modification, negative patients without MRI modification. We found that in orthostatic examination we had positive changes in 66% of patients. That means that up to 70% of cases of supine, standard supine examination of the lumbar spine, we can miss or underestimate a diagnosis. And so imagine how is important for the clinical management of patients. This is another case of, as we depict the bulging of the disc that is evident only in weight bearing, and as well as the increase in the bulging of this other disc. Other case depicting the evidence of annular fissuring in axial scan before and after wet body scan, and this highlighted fissuring. And of course, this come together with an increase of the narrowing of the central spinal canal that is not evident at rest. We also learned that imaging under load can make different effects on posterior elements, so not only disc, but only ligamenta flava, and as you can see in this case, the thickening and the ligamenta flava becomes evident upright, and they can make increase a narrowing of the central canal stenosis posteriorly. In this other study, we demonstrated how with MRI imaging can unmask also the presence of nerve root compression at the level of the foraminal level, caused by the association of increase of disc bulging and protrusion, thickening of the ligamenta flava, and facet joint osteoarthritis. This is also another case. We can see fluid inside the facet, and in the upright position, the fluid moves downwards. There is a bulging of the yellow ligament that narrows the lateral foramina, and there is also initial subluxation of the facets. What is important for diagnostic spine instability that by definition is imaging under physiological loads. Why it's also important? Because radiologists, orthopedic surgeons, and neurosurgeons look instability from different point of view. So we look mainly at anatomical alignment. Orthopedic surgeons care more about hypermobility and motion related pain, and neurosurgeon to neurologic deficit. So with baric MRI can be a comprehensive modality to speak the same language about spine instability. And again, we already seen these cases. We have subluxation of the facet determining lumbar spine instability under load, and also in this other case, the evidence of the degenerative posterior stasis demonstrated by dynamical MRI. Spine instability, very important for preoperative and postoperative examination. The patient at one point at TELESDA was not able to correlate the symptoms of the failure of the surgical stabilization with the symptoms. With G-scan, we could demonstrate the level of stability that was above the level of the surgical treatment. So again, the importance of a correct diagnosis for the more appropriate treatment for the patient. Different findings to interpret also, but the evaluator experience has a low impact on the assessment of spinal instability if we use a correct classification and if we train appropriately radiologists with dynamic scans. We also published a study investigating the role of overbearing MRI in patients without evidence of disc herniation, but with no specific low back pain that we know affects as many as 80% of patients with low back pain. And in particular, modic changes, modic 1, have been advocated to be a potential cause of low back pain. One of the theories for modic changes is the biomechanical stress theory. So the increased stress on the end plates may cause the development of modic changes. So we evaluated patients with modic changes and low back pain in standing and upright position, and modic 1 changes increase in up to 70% of patients, as you can see here in this example, together with the reduction of the disc height. From the clinical point of view, 78% of patients also reported an increase in pain during standing that was correlated in up to 73% of cases with the increase of modic changes. So our imaging results also suggest the evidence of the biomechanical stress theory for the development of modic changes with end plate fissuring causing a water redistribution from the disc to adjacent bone marrow and increase of pressure and pain. So what can be the future of weight-bearing MRI? There are probably several different predictable scenarios. Of course, the technological advancement in the scanner with faster imaging, more sequences, more detailed imaging, and reduce scanning time with an increase in imaging service volume and workload, also due to the increased accessibility of weight-bearing examination. This will lead to increasing volume of information derived from biomedical imaging, with potential also error increase, and of course a greater distribution of the equipments will take the need to standardize the indications, the protocol, and also the reporting between different readers, also with different experiences. One of the tools that can aid in the future is the implementation of computer-aided diagnosis. So, and these are the results that we presented at the last CCR Congress with the use of this CAD software by Esaote, that is QSpine. That is a tool for visualization and quantification of biomechanical changes of the spine that compares weight-bearing and upright MRI examination. The system has a wizard tool that provides a semi-automatic segmentation of the spine structure, performs both in recumbent and weight-bearing scans. After segmentation of the vertebrae, the wizard tool automatically calculated all these parameters, including the lordosis angle, the vertebral height and the vertebral wedging, the listhetic index, the intervertebral angles, and also all the spinal curvature angles at all single spinal level. It also provided also a continuous spinal canal section values at every single level, and at the end there is also an automatic comparison of the recumbent and upright MRI position with a preliminary report indicating either qualitatively and quantitatively or the numerical values of the analysis. In this preliminary study, we evaluated MRI images in 51 patients, and we calculated all these spinal parameters either manually and using Q-spine. And manual measurements were made by an experienced reader and an unexperienced reader. The results, as you can see from the graph, show an significant increase in the inter-observer and inter-observer performance, and also an increase in the reproducibility of measures. As you can see, the values measured by the inexpert and expert readers manually and with the PACS. We also evaluated the workload of this process and the processing time, and we found a 90% processing time reduction. And you see previously how many measurements we took with the Q-spine. So this approach, of course, provides a time-saving and comprehensive analysis of several spine structures and parameters. It provides high reproducibility that can be used to compare not only with bearing and upright studies, but also to compare longitudinal studies, follow-up, pre- and post-operative imaging, and different readers, especially for inexperienced readers. Thank you very much, and I'm happy to read your lesson.
Thanks a lot, Federico Bruno. You really show how you make a lot of research since, I think, 12, 15 years using these machines, and every slide was represented by a scientific publication. So literature, it's also a really important point from our side, as Dr. Majani is doing also, Dr. Monetti will show also, Professor Villanova. Every our luminary are working on that, but mainly the Giscany University has this purpose, to make research and scientific publication in this innovative and revolutionary application. So now it's time to honor you also. So I kindly ask here to come Professor Kai Villanova and Professor Monetti. You can. Sciarpa. Thank you very much again. Okay, now on our agenda we should have the Code of Ethics by the MC. Unfortunately, is not present, so we can skip directly to the last presentation of this morning. So I kindly ask here to come to Dr. Rosie Setiawati. Is correct my pronounce? Setiawati, okay? From Indonesia, is Head of Radiology Department, Faculty of Medicine, Universitas Airlangga, and working in also Surabaya Orthopedic and Traumatology Hospital. Thanks.
We'll find my presentation as well here. Okay.
If you need, you have the pointer.
Yeah. Okay, thank you. So I will make a pointer from the slideshow.
You can do
this here. Okay.
like this.
Yes. Thank you so much. Okay, thank you so much for. Yeah, I need lower. That's okay. Thank you. Okay. Good afternoon, ladies and gentlemen. Hi, everyone. Introducing me, my name is Rosie Setiawati. I come from Indonesia as well. And thank you, Mr. Giacomo, for introducing me. And first of all, I would like to say my thank you to Esaote for inviting me to this wonderful meeting, and also for Professor Mahajan and all the local organizer for all the hospitality. I enjoy so much. And what I'll talk to you for today's presentation is the added value of weight-bearing MRI in the assessment of the knee pathologies. I think most the previous speakers already emphasized and described about the knee weight-bearing MRI. So I just want to convince again about how important that knee weight-bearing MRI is important for the patients to have more adequate and proper treatment. And before I start my presentation, I will show you, this is my private hospital that I work in. I work with that. Our weight-bearing MRI is installed in this orthopedic and traumatology hospital. And in Indonesia, we have only two weight-bearing MRI so far. So I hope that by promoting and always educating about this weight-bearing MRI, so I hope that we can increase the number of MRI unit in Indonesia. So usually we have weight-bearing MRI in particular reasons and due to our prior indication to have this kind of examination. And unlike other speakers, in my centers, we only have this weight-bearing MRI. So you can imagine that the orthopedics and the clinicians for the physic and rehabilitations department relies on this finding of this weight-bearing MRI. And we have almost about 7 patients every day. Okay, so the highlight that I want to convey to this presentation, that introductions, and I will to show you about the pathologies, tibiofemoral compartment that are osteoarthritis, ACL instability, meniscus pathology, and the pathofemoral instability and take-home message. Okay, so as we know together that MRI is a promising diagnostic tool to evaluate the soft tissue in the joint because they provide the best or the higher intrinsic and contrast and spatial resolutions in the knee joint with the multi-parametric information. And the standard knee MRI, because I used to do to evaluate the knee joint with the 1.5 and 3 Tesla tube, so normally perform in the standard supine position under non-weight-bearing conditions. So that's why, yeah, because in most patients that the knee pain is suffered from the active transition between the extension to the flexion about 20 to 30 degrees of while the patient have a normal activity. So that's why sometimes standard supine knee MRI may demonstrate the pathology, the exact pathology related to the symptoms. So based on these findings, so many symptoms and pathologic occur when the patient are in weight-bearing position. So that's why we want to show that there is a differences between the finding between the supine and the weight-bearing MRI. This is how we do the MRI, the positioning of the MRI. Usually we do the weight-bearing first. And we are not doing a lot of sequences because I know that the patient will suffer for the long time scan if we do complete. So usually in the weight-bearing we do only 2 sequence and then we continue to weight-bearing a non-weight-bearing sequence. Sometimes we also need to do the dynamic scan. So it is possible to provide multi-parametric and multi-position of patients as well. And in this weight-bearing MR, we also have a dedicated for MSK that we call it SPAT. This is spin echo Dixon that may be ever described by Professor K, that the SPAT is provide the morphological information, the fat suppression, that this is provide and good for identifying the MSK pathologies that susceptible to PD contrast like a fracture, edema, or tears. They also have X-bone sequences that the X-bones provide the morphological information and fat suppress based on the gradient weighted contrast. So this sequence provides a higher tissue contrast with less muscular detail. We also have metal artifact reduction because we know the consequence of the low magnitude that will can also see the lower artifact. So this sequence may help us to reduce the artifacts resulting in for the implant. So we still can evaluate the adjacent structure or surrounding structures that and not bothered by the artifact by implant. So the low field potentially more suited for the imaging around the metallic implants because the metallic artifacts in low field MR system is reduced. Compared to the high field MR, the stronger magnetic will result in the other artifact. They also have the 3D SAR. This is a sequence also the sequence that dedicated for the cartilage as well, because we can see here very nicely the cartilage. We see the healthy cartilage here is very nice visualized on this coronal and axial. So it is also may help us to provide the good image for cartilage. And as described in previous presentation that dynamic MR but to the highest, we can see the true motion technique and we can see is there any impingement or maybe any instability of the soft tissue as well that we can see on the dynamic that we cannot see it in the only supine or non-underload MRI. So this is also one point or one key that this is a promising rule in particular to solve the problem, especially in the sport medicine problem. And this is a movie of this, let me, sorry. Oh, okay. Thank you. Yeah, this is, we can see, this is a normal condition that we can see the fat pad can flow through inside the anterior interval and then doing the flexion, they will come out and it may allows the joint movement very smoothly occur in normal situations. But in abnormal situation, we will see is there any impingement could be occur during this dynamic image. And the first about the tibiofemoral osteoarthritis, that we know that tibiofemoral kinematics evaluation is also important for assessment of OA symptom patients that are dependent of the specific movement and weight bearing, because this is regarding to the BMI of the patient and the activity of the patient as well, and the body position of this knee joint as well. And the abnormalities have impact on the patellofemoral kinetics and kinematics and possibly causing the long-term chondral damage. And the significant changes in fat pad sometimes also influence during the full arc of knee flexions. So by doing this weight-bearing MRI, we hope that we can see the progression of the knee OA, the effectiveness of joint reconstruction surgeries, and we can see the origin, the patellofemoral pain, as well as we can see the functional and in vivo investigation of the knee joint as well. So this is the case, first case in 67 years old woman. We can see a non-weight bearing and weight bearing. We can see the differences with the joint space narrowing, and we can see the cartilage loss here very nicely. And there is extrusion of the meniscal seen on the weight bearing on coronal sequences. So it will, it will explain that how can we predict the complication or the outcome of these patients so that we can give the information for the surgeon to do further treatment to this patient. And this is a sagittal, this outface sequence that we can see the contact area, the contact area that may influence the cartilage on this area. So we can see very clearly which part that we have to maybe treat it very well, and then we can see the complication or maybe the prediction of the outcome to patient. And about ACL tear, about the instability of the knee joint, that we all know that there is a primary signs of total tear and the partial tears, that usually in the total tear we cannot see, or there is a non-visualization of ACL, and there is a discontinuity, the ligament, as well as the changes of the signal intensity inside the ligament, as well as the thickening or wavy retracted appearance during the MRI. And partial tear usually shown as the intact vesicles, but sometimes the ligament is become thickened or with T2 hyperintense signal. So sometimes we also add the secondary sign, secondary information on MRI, that we can see depression of ACL fiber, the anterior displacement of the tibia, uncovered lateral meniscus, as well as hyperbacloid posterior cruciate ligament. And as a study described with Professor Bruno, that there is a study which compare the standard MRI and weight-bearing MRI in detecting the ACL tear. So from this study, they shown that there is an increased accuracy in detecting ACL tear by doing this weight-bearing MRI, because we can see more evident, more prominent, more obvious finding of indirect and some direct sign of deflection for lateral case of tear that we can see, we can measure the Blumenstadt and ACL angle. So if there is, we do in weight bearing, so it must be depressed the remnant ligament as well. So we can found that the angle of the Blumenstadt and ACL ligament is increased. And we can also see that this is a hyperbacloid PCL seen on the weight-bearing MRI. And we measure about the anterior tibial translation. So there is a differences between these two images from non-weight-bearing and weight-bearing. So we can see there is more prominent on tibial translation anteriorly, and also we can see there is an uncovered lateral meniscal finding. So it can help us to conclude about the ACL tear, because sometimes the orthopedics still wondering whether this diagnosis is correct or not. But if we add some information that may be more confirmed for the finding of ACL tear, maybe will help the orthopedics to do some treatment. And it's a case of the ACL rupture and anterior tibial translation, that this is the ACL tear, and this is non-weight bearing, and this is a weight bearing. So we can see the ACL insufficiency under the load condition. And this is another case of the ACL rupture, MCL, and medial meniscal tear in 20 years old girl, that we can see, as previously described, that we can see the depress of the ACL ligament remnant fiber, as well as the uncovered lateral meniscus. And we can also see there is instability of the medial tibiofemoral, by seeing there is an increase of the distance between the tibiofemoral space due to this instability. And this is the case of partial ACL tear. Yeah, sometimes we don't know exactly whether this is correct or not, but we do the weight-bearing MRI, so this is confirmed that this is more evidence and prominent, and see there is also a fluid collections come out in this area of the tear that we can see, we seen from the weight-bearing MRI. So this is the case of the post-ACL reconstruction and graft repair. 2 years ago, the patient suffered and came to our hospital to have some operations of ACL. So now he is an athlete, and now after 2 years, he came again with the problem after having, fell down after a sport, and then we see there is a retear, a retear of the graft of ACL, that we can see the ACL graft is nicely seen on the weight bearing rather than the non-weight bearing. We can see here that the graft remnant is seen on the weight bearing MRI. So it can help the radiologists to give information about the finding of retear. About the meniscal instability, remember always the biomechanic and kinematics function about the joint is also as our priority to be evaluated, that the complex interaction between the tibiofemoral joint and meniscal kinematics with the meniscal translation also combining with the meniscal distortion from compression of the femoral condyle on the menisci. And usually before, the meniscal stability evaluated only through or during the arthroscopic methods. But right now, we provide the evaluation to see the stability of the meniscal tear. So we not only just see the morphologically, but we can see how far is the instability of the meniscus happen in certain patients. So usually during the flexion movement, there is an increase of meniscal slope with potential decrease in load in anterior horn and concomitant increase the posterior horn. This is how the explanation why in the posterior horn of the medial meniscus is more sensitive to have instability that we can see also in weight-bearing MRI. Professor Perile have a study to identify the new approach to the analysis of meniscal pathologies. This is also described by Professor Bruno, that the study not only just seeing the morphologically, but also see how the meniscal fragment is moved or maybe herniated, by doing both supine and weight bearing. So they classify into 4 grades, and then we will define whether this is unstable or stable lesion by seeing the protrusion or extrusion by doing the coronal or sagittal image. This is the case of from the weight bearing. We define that this is stable tear or degeneration of the meniscal, that this is tear type 2, but after we do the weight bearing, we can see a tear of these meniscals is going through to the articular surfaces, so it's increased grading of the tear is as well because of we doing this underload MRI. So we can see very clearly about the tear from this to this condition. It is also another case of unstable or fragmented meniscal that on weight bearing we cannot see the tear fissure inside the meniscal so nicely. So, and also in the anterior horn, we just see there is an increased signal intrameniscal, but when we do the weight-bearing MR, so we can see there is a linear tear on the anterior horn of the medial meniscus, seen very more evident on weight-bearing, and we can see more fragmented meniscal on sagittal, and we see there is unstable because there is also the posterior horn, the medial meniscus. And this is another case of the meniscal tear. Yeah, we can see on the weight bearing and non-weight bearing, we can see the tear is more evidence on the weight bearing as well. About the patellofemoral instability. So the patellofemoral instability, as described also in the previous speaker, that the patellofemoral joint kinematics and can change the quadriceps contraction, muscle contraction, that we cannot see this condition on non-weight bearing because the quadriceps femoris tendon will relax, so we cannot see there is a maltracking of the femoral patellar joint or maybe instability of patellofemoral instability. So it's very important if the patient have the anterior knee joint or maybe a habitual subluxation or maybe sometimes there is a discomfort sensation in the anterior knee to do the weight-bearing MRI, because we can provide the more information about how the patellar will move under contraction of the quadriceps femoris muscles. So the greatest tendency of patellar lateralization was not found in the full extension, but there is occur in the active 20-degree flexion of the ankle. Yeah. So several causes, the patellofemoral pain also caused by the patella alta or the higher riding patella is also thought to predispose the individual patellofemoral pain. The changes of the patellofemoral joint under load with the particular focus on the joint contact area will result in the greater cartilage deformation. And the difference between the patellofemoral alignment and tracking under loaded and unloaded condition must be adequately addressed to establish the appropriate treatment. So this is another case about the patellofemoral impeachment. We can see here that there is a fat pad impeachment on the suprapatellar fat pad. We can see very nice on the dynamic scan. So this is a case of difference between the supine position with the weight bearing. So we can see significant, there is significant changes of the position of patella, because there is a patellofemoral malalignment and tracking under loaded condition. So I think many patients may have this kind of situation, because in my experience there is light it bother the patients every day. So we try to do this weight bearing as our routine examination. So finally we figure out that there is many patients with this condition of maltracking. Diagnosis is important because the underlying pain may differ between the patient of maltracking if we compare with normal patellofemoral biomechanic. So we can also do the measurement during the weight-bearing MRI. We compare with this both situation from the install Salvati index, the lateral patellar displacement, and the lateral patellar angle, and as well as the lateral patellar tilt. So if we see there is a differences significantly, so we can confirm giving the complementary and additional information that the patients have unstable patellofemoral joints. So this is case of the female 55 years old with the anterior knee pain and OA. There is a do this, I think we. So while we doing this weight bearing MRI, so we can we measure this and then lateral patellofemoral length is also lengthened on these situations. So we can confirm also with the lateral patellar angle. So we can see that the patellofemoral joints have instability. And also the last is lateral patellar tilting. So with the study by Moriani, they say that there is association of the standard and weight-bearing MRI, and the LPT is measurement may represent most accurate to predict the possibility of the patellofemoral instability. And this is the case of a young female patient with habitual patellar dislocation. At the time, she is recommended to have review since she is a doctor, so she still why she yet. So this is the condition of the maltracking of the patellar. So since the weight bearing, we can see there is already have a patellar previous case. By doing the weight bearing MRIs, there is increased number of the measurement. All in the parameters, we can see the increased number. So this is problem for the patient. Not yeah. Right now, and this is the previous, I will show you that this is her previous MRI with 3T. So if we compare from the first condition of the patellofemoral joint about 2 years ago until right now, there is a different significant changes of this instability of patellofemoral. So right now we recommend this patient to do the surgery because we can see the situation of this maltracking is getting worse. And this is the last of our case. This with the back instability. So forget to do this weight bearing with axial because yeah, sometimes we can miss something with the anterior knee joint. So the conclusions is the weight bearing and dynamic MRI is a promising diagnostic tool in detection the pathology around the knee joint, morphologically, as well as the stability of the finding found on both images. And in the unloaded and underloaded condition is very important and must be adequately addressed by radiologists who work with the weight-bearing MRI to establish that the clinician will give the best and appropriate treatment to the patient. And these are my summary, what meniscal instability and patellofemoral joint instability during weight-bearing image. Thank you so much for your attention.
Prova. Okay. Thanks a lot for your outstanding presentation and very, very good on deep on the knee weight MRI. About spine, but the joint also can give you an important value. Should benefit for weight-bearing MRI. Thanks a lot. So I kindly ask again, sorry to come here because it's also your time. So it's time for your honor, and I kindly bouquet, and Professor Majan. And I would say Federico Bruno, because you mentioned from University of L'Aquila, they work a lot on the knee, so it will be a pleasure to have. Okay, thank you very much. So now it's time for question and answer. So it's time for the audience. We have 10 minutes for Q&A. Oh, I see many hands already raised. I would like just to kindly ask to Dr. Rosi, Dr. Federico Bruno, and Dr. Babu, if you can come here so they can make the question. So for the 3 presentation we have done. So first we have here the first one.
Gerd Müller, orthopedic surgeon in rehab now. Congratulations to all of that. I would actually have 2. Hello. Gerd Müller from Active Health here. Congratulations, it's a lot of eye-openers here. I have one question on the spine and one question on the knee. The spine question is regarding creep. So we have patients who have even radicular symptoms, lumbar, after a longer duration of standing. And you had the or so, and when I looked at the geometry, there was not much change. So my question is, have you had indications of creep that if patients stand for 2 hours or so, or 1.5 hours, that there is creep, more plastic deformity? In a practical way, should we have patients standing for an hour before they go into the standing MRI?
Should I answer? Yeah. So nice question. I think so you are into that subject. You are asking the so detailed questions, so you must appreciate understanding on that. So we have, for the study purpose, we have taken 24-hour MRIs. You have seen that one of the study which what we are doing. In that we take in the morning and also continue the same patient till 12 hours in the night and also next day morning. So we obviously see that the morning disc height is very high. And then by end of the day, the disc naturally gets the height reduced. And your question is if you ask the patient to stand before MRI.
Or I send them to you in the evening.
Yeah, if you send me to me in the evening. So these are the 2 things now which we take on the same time, supine and standing. Even if you send in the morning or you send in the evening, so we'll make the patient to take a supine MRI and make the patient walk for some time, and then we'll ask them not to sit. Walk around the OPD somewhere in the center and then come back for a MRI in the standing. But it all depends on how much the patient has got pain. If the patient has severe claudication, he may not be able to stand, and you also no need to do the MRI, also standing MRI. If the patient is so clear on his symptoms, so there is no need for a standing MRI. So it's only for the borderline cases where you exactly want to find out reason. And one more reason for why we do this standing MRI is the patient has got a severe L5S1 stenosis. We are sure that
there's hardly ever a L5S1 stenosis. It's L4-5 and 3-4.
Yeah, it's in the sense like I see a lot of patients in Indian perspective. There are lot of people will have lytic listhesis. They present with L5 lysis. They come with L5S1 listhesis or lysis with stenosis, but there is a subtle 4-5 stenosis. So there comes the question whether just doing L5S1 is enough or you want to do 4-5 as well. So the symptomatology wise, it's fine for the patient if you do L5S1. The claudication distance is say 100 meters. The claudication distance for 4-5 will be 150. So the patient will sit even before the 4 or 5 symptoms come in.
You always have an L5 root symptom in
Yeah.
both cases. It's difficult to distinguish.
That's what I'm saying. Patient will have, I'll say, because we are going so detailed into the one, say L5 radiculopathy is 8 out of 10. And 4-5 radiculopathy causing L5 radicular symptoms is 6 out of 10. So the 8 out of 10 will force the patient to sit down even before the 4-5 symptoms come in. You got my point? There are 2 levels of the different grade of stenosis. One is borderline, other one is moderate or severe. So if you address the severe one, patient will get very good symptoms. But if he walks for more than the severe stenotic symptoms, he will get the other level pain. So those things can be picked up on this standing MRI.
Thank you.
Whether to address both the levels or not.
I have one more really practical question. Would like to have your advice on it. A daily situation. I have a 55-year-old person with clear meniscus signs. And I have the luxury to send them to Harsh Mahajan, who has a standing MRI, has a 1.5 Tesla, has a 3 Tesla. So what do I do now after hearing you? Should I send him to the 3 Tesla high resolution, quick in, quick out? And if it's not clear on the meniscus, send him back again for the standing? Or should I right away send him for the standing, skip the higher resolution? What would you recommend to me in a first go MRI situation?
Me or Professor?
Yes, meniscus.
Okay. Okay, thank you so much for the nice questions. This is the question that many times being asked because this is like the surgeon wants to confirm about how we can find the best solution. Okay, so in my experience, because I also work in the 3T, 1.5 and low Tesla MRI. So based on the situations, because not many conditions that can be covered in all situations. So if we have 3 machines as well, so I prefer to send the patient first because we prefer to send the patient first to the low Tesla. Because in this MRI, we can provide the morphologic finding as well as the function. Because as I show you that the quality of image of this machine, I think is still good that we can show to the surgeon to decide what the best for the patient. I think I would do that. Yeah. Maybe Professor Bruno have same.
Yes, just add a brief consideration. For spinal imaging, I think we saw that in up to 70% of patients, the imaging pictures and the clinical picture changes. So maybe dynamic imaging can be not the standard, but really recommended, especially for patients that are referred maybe by general practitioner, because in sometimes we can make the patient go home without a definite. For the knee, it's important to have a specific clinical indication. And I think that in the lecture during the day, most of us showed similar things. So this means that I think nowadays there is growing a stable semiotics about weight bearing, especially for some regions, for meniscal instability, posterolateral instability, and patellar maltracking. So maybe this can really be not only a matter of research and something anecdotal, but really something that is of clinical value in the daily practice also.
Just one, if you allow me, one small remark on the spine. It's brilliant what you show and all. What we have to bear in mind, we have to really distinguish the radicular situation and the back pain situation. Any study that we do on back pain, we have a difference in the mean between people with back pain and without back pain. But the variance is huge. Whether you take a depression index, whether you take muscle strength, whether you take mobility. So we always have to be modest if we talk about back pain and correlation to symptoms, to the imaging
Yeah,
result.
of course.
Hello, my name is Margarita Natsika. I'm from Athens. I work in a private sector, and I'm a musculoskeletal radiologist. So I have a question to all of you first. Has the use of this system affected the number of X-rays, the dynamic X-rays that you perform in your departments? I'm talking this because I'm asking about this because of the cost effectiveness of this system first, the environmental or the human protection that maybe this has affected us, and if it's so, this is a very good a good market for to use these systems also, not to expose people to more X-rays. So it's my first question to you, and I have another one.
I don't think we have still reached a area where we can say we can completely avoid X-rays. The radiology has got its own potential in few things. That's what the study, our main aim of the study is to do the standing MRIs and load-bearing MRIs and compare the same with the standing X-rays and load-bearing X-rays, then find the relation. Maybe at some point in time we can come to definite conclusions where we can say that X-rays whether needed or not.
Yeah.
But at present scenario, being from Indian scenario, what we are trying to do is to correlate the upright MRI features with the X-ray, so that even those centers which doesn't have the upright MRI can correlate the symptoms with this one. So what we have proved in that traction MRI is by applying traction, we are able to reduce the listhesis by 50%, translation by 50%. So 50% translation can be easily picked up on a traction X-ray. So this 50% translation in vertebral body is causing 50% increase in canal diameter. That's what the MRI showed in the axial sections. So if you can say that in your traction X-ray, if you are able to reduce the listhesis by 50%, so your MRI is also going to have 50% increase in spinal canal. So that can give a retrospective idea that even with the supine MRI and the traction X-ray, you can correlate how the canal is going to be. For that, you need a large data to answer your question, to reach that conclusion that this can avoid X-rays. But at this point in time, X-rays still are the gold standard to study the dynamic point of spinal movements. Maybe at some point in time we may reach that area. But the limitation of the lumbar MRI is we can only get the loading upright, but we can't get the flexion extension. For cervical, we can do that. For lumbar, still we can't get the flexion extension. We just get the loading. We tried with the lean patients, turning them onto the side and asking them bend forwards and bend backwards. We are yet to come out with this, but it can't be fit in the thing.
Okay, thank you. Oh, we still answer? Okay.
The same question.
The same questions. Thank you for the questions about how important, whether we compare with the X-ray, is it still have to do or can be avoided by the MRI. So in our experience in my center, we still do the X-ray with standing. So because we know that for MSK, we have to exclude first about the bone and the joint problem first by seeing the X-ray first. And we can see also from the X-ray if there are any hematrosis, lipohematrosis that can be additional information for us to do the MRI, because in my centers the insurance cannot afford in every MR examination, so we have to select. So that's why we still do. If there is something abnormality found in the X-ray come from the soft tissue, so we will continue with the MRI, especially with the weight bearing. This is my experience. Thank you.
Yes, also in Italy there is an issue about indication and justification for diagnostic procedures. So of course the first line is X-ray, and MRI is prescribed by the orthopedic or specialist prescription. And of course regarding weight bearing MRI, also targeting the clinical question will be very useful to enhance the diagnostic possibility and to focus on the clinical question.
My second
Yes, so just to add on to what he has said, more than the load-bearing X-ray, this dynamic MRI in the knee can avoid diagnostic arthroscopy. You want to check the tear whether it's stable or not. What you used to do is put a scope in the joint and check the instability under vision. So those things can be avoided. The interventional procedures of diagnostic arthroscopy can be avoided by just checking the dynamic MRI and the motion and kinetic things.
And just a few words, I want to ask you whether the system has really a role to play in shoulder and hip instability.
Yeah, shoulder.
Dislocation, shoulder dislocation.
Yeah, in the afternoon you will see also more cases related to shoulder. I just update you on, sorry? In the afternoon you will have more cases related to shoulder specific, but I leave the answer to them that already show other cases, yes.
Yeah, I think Mahajan sir has showed in the morning how you can check the shoulder instability even by putting finger pressure and then check the defect. And this has got a huge potential in the shoulder instability as well. I think there are a few questions on the back somewhere here.
Yeah.
Yes, sir, please.
Babu, my question is to you. We were just discussing the weight-bearing MRI.
Sir.
You have added a new concept of traction.
Yes.
We know that the traction is essentially to decrease the spasm. This is what we were learning over ages.
Sir.
In the presence of an intact anterior longitudinal ligament, annulus, posterior longitudinal ligament, ligamentum flavum, and in a spinal position, do you think that you are able to dissect?
Yes, sir. In an intact spine without instability, it may be difficult. But the patient has got some dynamic instability, the segmental instability or angular instability or a subtle instability where that can be demonstrated on X-ray. The instability which can be demonstrable on X-ray can be demonstrable on a traction as well. But what you are talking is a solid fusion, going into the stage of stabilization, osteophytes, fusion. I don't think that's not going to work. But also this indirect decompression is targeted to those patients who have a mobile aesthesis without opening the canal from the back. You just jack up the anterior disc space and then the canal can experience of doing these cases. This is coming up in a big way now to avoid the canal entering, and that can reduce the dural scarring. So we keep the spinal canal pristine. So we don't touch the spinal canal at all, and everything is done in the front. The concept is all these things happen because of disc collapses, facets sublux, and that cause stenosis. We reverse the same thing by jacking up the anterior disc space. So everything will fall in place. But whether it falls in place or not is by clinical judgment till now. So this MRI can show you how much it can be done. And definitely the surgery will add on to the distraction what it's shown on the thing.
All right. I have a question, two questions, one on the knee. You showed about the ACL injuries with. Do you also come across common peroneal nerve injuries? Can you pick up on weight bearing? Because we have seen association of common peroneal nerve injuries with posterolateral and ACL. That is question number one.
Okay, about the peroneal nerve, I don't have any experience about of evaluating the peroneal nerve compared with the the incident of the ACL tear. Maybe you have.
No, me neither. No, me neither. But
all right. My second question is on the spine. Sir, the weight-bearing spine MRI, so suppose you have multiple level discs, can you make out which is the more offending discs or what discs we can leave out in multiple disc scenario? So can your traction or your weight-bearing MRI tell us which is the more offending disc?
Yeah, so in a multiple level discs, the level to be operated and which is the culprit is basically by clinical correlation. We go by dermatological distribution and the dermatome which that now supplies and then try to correlate the same thing. But this will give you the objective evidence even before surgery. If you have a if you're suspecting multiple stenosis and your symptoms are out of proportion, so that's what I was discussing in the morning. The patient comes with you L4-5 stenosis and a supine MRI. So we'll expect the pain going on the lateral side of the leg. Say if the patient has got anterior thigh pain with the same MRI, then I have a doubt whether patient might be having a L4 radiculopathy as well. And there might be subtle bulge at L4-5. If you subject those patients to standing MRI, you may see that 4-5 is bulging. But this is mostly useful in a post-operative scenario. In the post-operative scenario, patient who underwent very good surgery for L4-5 stenosis comes back to you with a different kind of pain, not the previous surgical pain, something on the sole of the foot or anterior thigh pain, then any number of supine MRIs is not going to show you where exactly the culprit. So your dynamic X-rays will show you something, and in that scenario we'll go by clinical judgment that there might be 4-5 stenosis or 3-4 stenosis and will operate on the patient. But this loading MRI can show you the adjacent segments, what's happening exactly.
If I may just address that question, because that's a very important question. What we do in addition at times is do MR neurography and functional nerve imaging, where you're able to see signal alteration in a specific nerve root on diffusion. There may be no structural change and pressure would be seen at multiple levels, but if you see signal abnormality and restricted diffusion in the nerve root at a particular level, then that may be the offending level. Of course, everything has clinical context.
So will that
and
be
this
done
we
in
do at 3 Tesla.
That needs 3 Tesla.
Yeah.
Yeah, if you don't have 3 Tesla, just inject xylocaine into the root and then see root block. The diagnostic root block will give you the same result.
Hello. Thank you, Dr. Roji, for showing the excellent cases. So I have not a question, but the comments related the experience related with that. So obviously you shown so many the indication how for the weight bearing, particularly the knee joint. The two indication I think in my experience is much useful. Probably the lot of the more experiences are required or more the studies are required. One is where the surgeons has the suggestion of the ACL, the instability, or you can say that the ACL is the structurally normal, but still the patient has a instability. So actually in cases like 3 Tesla, if you do this 3 Tesla or 1.5 Tesla, we feel that the ACL is normal. But the surgeons say that I'm suspecting the ACL tear. In those situations, the weight bearing MR is very useful because we can show that the stability, even the structurally is the ACL is normal. That means sometimes the ACL is redundant or is kind of thing. So still the patient has stability. Normal MR is, particularly the 1.5 MR is showing normal, but the weight bearing MR will show the actual instability because of the weight bearing. The second other thing is the kind of the meniscal instability or moving the meniscus. Not in like the meniscal tear. Obviously, you have shown so many the example of the meniscal instability where the tear was there, and then the more we can say that how much the tear is displaced or the extrusion. Obviously, so shown. Again, in many cases, what happens the normal, particularly the Wisberg type of the meniscus, where the meniscus is mobile, and if you do this the MRI in these cases, the meniscus looks normal, but the patient has a clicking sound. And the surgeons know that probably we are dealing with some kind of the meniscal tear. But in normal cases, the meniscus looks normal. And these cases, particularly in the weight-bearing MR, will showing that the meniscus is moving. It's not in the same location, particularly because of the lack of the support of the lateral meniscus particularly. So in those situations, the MR is, again, the weight bearing MR is very, very useful. And thank you for showing all the cases. Thank you.
Yeah, then we move to the last, after you, the last question.
No, I just
and
wanted
we
to
close.
add to
Yeah,
his.
yeah, no problem, no problem. Thanks. Go on,
So
please.
if you have a problem with a complete tear of ACL or a partial tear of the ACL, that's what you are. Yeah, that's what I'm saying. But your patient is having instability. So all you need to do is to make the patient hop. So if he is having instability in hopping, ACL is gone, right? For the meniscus, mobile and otherwise, same thing you can do. You make him jump on both his feet and then move forward. So if the meniscus is mobile, he will. Yeah, that's what I'm saying. Yeah, but if you could do the correlation, then you'll probably.
Okay.
Uh, 1.5 Tesla or this standing MRI?
Yeah, scoliotic with adolescent idiopathic scoliosis, which is a more of a structural thing. There is no need for a weight-bearing MRI because so what we are going to correct is only the shape. But if you are dealing with the adult degenerative scoliosis, the patient has got a lumbar scoliosis and degenerative pathology. There, definitely the load-bearing will have a role because we want to make sure that whether the correction of the deformity is enough or you want to correct the stenosis also and how much you want to decompress. All the sagittal parameters, what we are used to measure on a spinopelvic indices, what we are going to measure on a standing X-ray can also be measured in the standing MRI. So in the degenerative scoliosis, it has got a specific selective, very good important role. But only the functional limitations for this MRI is getting a whole spine standing. Getting a whole spine standing is possible, but you have to use a stitching software and get the whole spine from cervical to lower. And for adolescent idiopathic scoliosis, they found out that there is some torsional herniation which can be picked up in dynamic load-bearing MRI.
Yeah, hi, good afternoon. My name is Dr. Sohit. I'm a neurosurgeon at Lady Hardinge Medical College. So my question is for Dr. Babu. So sir, you have shown those 4 images in which cervical spine MRI is done when a patient is lying supine, then another one when patient is lying sitting, then sitting flexion, sitting extension. Now, as a newcomer, I would say that if you look at the first image, I would just decompress it anteriorly and that should be enough at 2 levels. Same patient, if you look at it, patient sitting, you have to decompress 3 levels anteriorly, like one of the people had said there. Same patient in supine, in sitting and in flexion, you have to decompress anteriorly as well as probably posteriorly. And the fourth one again, you are going ahead with 3-level decompression anteriorly and maybe fixing it posteriorly as well. So with this technology that we are having, are we actually overdiagnosing and adding it more to the confusion of how we go about treating these patients, or is it where do we draw a line as to okay, we'll just go with the anterior discectomy and fusion or posterior decompression?
I actually tricked senior most spine surgeon Ajay Krishnan also. It all depends. It all depends on what we are dealing with. So all these things are not for a routine. So the reason for why I did this MRI is that there are 2-level compressions in the supine MRI, but I was not sure about the clinical symptoms. Those 2 levels cannot cause the profound weakness what patient has. So that instigated me there is something wrong happening. And also second clinical instinct what I got is there is a C5-6 and C6-7 stenosis, but the patient has got a signal intensity a level above, not at the level of the disc. So that brings to me a suspicion that there is something happening in the patient is dynamically moving. So I took flexion extension X-rays and I could demonstrate some listhesis. But that doesn't reflect and that can't be, I can't be sure whether there is a stenosis happening at this point in time or not. So these MRIs actually brought into the concept. So what is exactly happening? Now I am convinced the reason for the myelomalacia happening a level above the stenosis is because of instability, which is picked up very well on a sitting MRI.
Last 2 very fast questions, please. There is 2 that we have to stop.
It's a very stupid thought that I passed my mind. Like we're doing an MRI in the supine and the standing. Should we also do clinical examination in the supine in the standing position?
We always do in clinical supine standing. in the, for what? For cervical, is it?
Yeah, for
Ah,
cervical.
yeah.
So we're doing all our examination in supine position. So like we're
No, no,
doing
no, no, no,
imaging in both the positions will
No, no, no. You do it in supine position because convenient for you. There is a bed, but patient complains you what he is facing when he is walking. Patient comes to you with unsteady gait, weakness, unable to eat, and all. So you won't be eating supine. He will be eating when he is standing and. So because our MRIs cannot provide you a weight-bearing MRI, we are used to this supine, and our mind got tuned to that. And this is all because of industry. Industry is pushing towards the superconducting magnets, Tesla after Tesla after Tesla. So that is good for getting a good signal. But the mechanical component is completely missing. That's what these guys have tapped that idea of including motion into the MRI. There are two different perspectives. So if you go for a whatever kind of TV, which have 4D, HK or something, then you get a better quality, better vision, better perception, better color delineation. But exactly the content, what you want to know is different. No? Seeing a 3D and a 2D.
Yeah,
Ajay,
there was something
don't ask
for
tricky
you.
questions. Ask simple questions.
For Naresh, Mahajan sir and Villanova.
Yeah.
Like for dynamics, for non-conventional way of dynamic loading, we have been using stress MRIs. But in whole of the session, what we covered, we never talked about MR myelography. Is that modality available with this? Because that would be very good for instant impressions of a root cutoff signs or an impression of a stenosis increasing, because that gives very clear differentiation as to an increase in stenosis than the exact axial cuts or a sagittal cut. So is that available with this modality? MR myelogram.
I think that's the post-processing can be done, not an issue. I think. It's a post-processing thing, so it's not the technology.
Well, MR myelography, it's a sequence that, as I have said, all these advanced sequences have always been implemented in high field. The problem is then, in low field, it has not been implemented strictly, but today, with this sequence that we have, for instance, I have, everyone has shown this SPET that we have seen now, and I have shown this Dixon acquisition. This, what is important if, with MR myelography is to show high fluid signal intensity and the background be very dark. And this is without contrast, of course, that this is what we can do in high field, and we are doing MR myelography. This, now, with this advanced software, we can perform. Probably we still have not used, I don't know if, I have not tested exactly, probably because the clinical, we have not requested. So that's what, as I was saying. So we need clinical questions, and then probably in my side, I have not probably performed, or, but I'm sure Dr. Magani, so that's why today we can perform.
It can be easily done. There's no problem. On this machine as well, we do volume imaging in any case in the axial plane. We can reconstruct them in any desired plane. MR myelography is, after all, a T2 sequence. In fact, even on high field 3T or 1.5T, somehow we've stopped doing MR myelography because the resolution has become so good that generally it's not as if MR myelography will add something. I remember my slides of early 90s when the first thing we would show an orthopedic surgeon was, or a neurosurgeon was, MR myelogram. That now we can get this and there's no need to inject intrathecal contrast, but it's absolutely possible. Second, regarding the question, are we confusing the issue by giving you, weight bearing, flexion, extension, especially in the cervical spine? And are the present day, norms of when to operate, what level to operate, are they changing with this? I think the more information, the more informed that a clinician is about what is happening, especially in a physiological condition, in flexion, extension, because that's how we live our lives. If we are able to give that, I'm sure with more data coming, you may end up modifying the way you approach, and we may learn that in about 20% of patients, we don't do the right thing because we don't have the right information. So I think rather than feeling, that our life is getting complicated, probably in a year, 2 years with more data, the patient's life will certainly become better, and maybe the outcomes would be much better because we had more information pre-operatively, rather than, having them go through the surgery and then realize we should have done at 3 levels or that we didn't do an adequate job. But it's all open, it's an open field for research because we've concentrated a lot on the lumbar spine. The cervical spine, I mean, we've been using it for 12 years. What Dr. Babu has shown in 1 year, I think it's an eye-opener even for us because we never concentrated so much on the cervical spine. Yes, and I may introduce Gerd Mueller. Gerd is a German orthopedic surgeon who for the last 10 years has been both in India and in Germany, more in India now, and runs probably and physiotherapy lab now in this part of the country.
Even on the diagnostic side, thank you very much, Harsh. I want to add that I think a very important part of indication for a surgery is how well has the non-surgical approach being done. And seeing from both sides, especially in the cervical spine, it's extremely poor here. It's extremely poor if I compare India to other parts. Even your terminology is different. I've been around a bit, but India, to me, is the only country where people call neck pain a spondylitis or a spondylosis. So you have a clinical feature like neck pain, and you immediately translate that into a structural disease. So we should keep things where they are. And in many instances, we have all these mixed symptoms. Degenerative scoliosis, very often it's very difficult to distinguish between radicular and non-radicular radiation. So I would say if somebody goes through a proper non-surgical regime for a limited amount of time, if there's no emergency, and in most instances in the chronic people we don't have an emergency, both for degenerative scoliosis, for neck pain, half radicular, half non-radicular, a proper non-surgical approach is very helpful even for the indication for surgery.
Okay. Thank you very much. I think we can close here. We have been, thanks, a very interactive session, and this is the reason we do this kind of meeting, to have important question and the possibility for the attendees to speak with our expert that share their experience with G-Scan. So now it's time, before to go to lunch, for the memorial award to the distinguished guest. So I kindly ask to announce the distinguished guest for these final awards. Thanks.
Yes, may I first invite Dr. Harsh Mahajan and Professor Monetti to be on the dais so we can honor our distinguished guest. The first name, Dr. Raj Bahadur, who is ex-Vice Chancellor, Faridkot University, and Director, Regional Spinal Injury Center, and he's been board member to DNB Selection Board, and we are honored that he's here. we also have amongst us a distinguished guest from the Indian Army, Colonel Gopinath. We request, he's the head of the Department of Radiology, R&R. He's amongst us. We also have amongst us the distinguished guest from PGI Chandigarh. He is president of Musculoskeletal Society, Dr. Mahesh Prakash. We request him to be on the dais, please. May I now please request Dr. Archana Gupta. She is chairman and head of the Department of Research-Based Institute, SGPGI, Lucknow. I may request Dr. Harsh Mahajan and Professor Monetti to do the honor. We have amongst us Dr. Anit Parihar, who is head of the department, King George Medical College, and he's heading the radiology department in KGMC, Lucknow. We have amongst us head of the department, Ram Manohar Loya, Institute of Medical Sciences, Lucknow. I may request Dr. Harsh Mahajan and Dr. Monetti to do the honor to Dr. Gaurav Raj Agarwal. May I now request Dr. Bikash Agarwal, who is Director for Genex Diagnostic from Odisha. Dr. Bikash. May I now request Dr. Sanjay Srivastav, Director of Chain of Srivastav MRI in Delhi NCR. Dr. Sanjay Srivastav. May now request Dr. Rajiv Kapoor, who is Chief Medical Officer as well as Head of the Department of Radiology in Government of Haryana, Panchkula. I think that is it for now. We may proceed for a lunch, but do remember we have excellent topics and speakers coming after the lunch. We should not miss it out. Thank you.
So now the lunch is outside here, correct? Diraj, the lunch is outside here. So we will meet here in 2:45. Is okay? 2:45, please. So we are not going to in delay. Okay? Thanks a lot.
I think it's perfect for you guys.
Okay.
So maybe we can finish earlier, because now we have the last session, a really important session related to not weight bearing, but mainly to dynamic imaging. So you will see how is important for the clinician and the indication that the clinician provide to the radiologist. So we will have the first presentation from Andrea Giorgini, and after Andrea Giorgini, that will present a specific presentation related to shoulder. Let me introduce you Andrea Giorgini. You can come here. Andrea Giorgini work at the University of Modena, corretto? University of Modena, and is working in the team of Professor Porcellini. They treat very, very famous professional athletes like in MotoGP, Dovizioso, Valentino Rossi. So they are very, very keen on MSK surgery, particularly for shoulder. So, thanks for coming. I leave you the floor so you can start your presentation. C'hai tutto, è tutto a posto? Hai bisogno di questo? Sì. Dimmi tu. Allora, sì. Questo avanti e indietro, e qui schiacci per il pointer se ti serve.
Ok.
Serve che tiro un po' più giù?
Grazie.
Va bene?
Yes. Thank you very much for the invitation. It's a great honor for me to be here. As Giacomo has said before, no, sorry, we start from the end.
Okay. Facciamo così, così, e poi andiamo su. Così, sei all'inizio. Qua giusto all'inizio?
Sì.
Ok. Direi che ora parte.
Okay, we're ready. So, I am an orthopedic surgeon. I work in Modena, in our hospital, in our department. We perform only shoulder shoulder surgery with Professor Porcellini, which is my mentor. And as you can see, I've seen a statue that resembles very my professor. They both beloved leaders. And first of all, I want to thank Professor Masciani and Esaote for allowing me to be here. It has been a very interesting experience. I hope also this speech will be interesting, even if the time is what it is. And I have no conflict of interest for this presentation. I will talk not on MRI, because the part of the MRI will be explained by Professor Monetti, with which we collaborate so much during our clinical practice. And I will talk about shoulder anatomy and why it's important to understand his function during movement. So, why is important? The dynamic imaging information in shoulder. As you can see, the shoulder is considered a ball and socket system. So the ball is very, very larger respect to the socket. As you can see the figure of the golf ball. It has got a huge range of movement all over around 360 degrees and a very little static constraint. So a high instability for definition. So I don't want to do a list, just a list of the structures. I want to understand why those structures are so important. So the capsula is very, very lax, and particularly in the inferior part, which is called the hammock, the inferior hammock. Ligaments are only a thickness of the capsula, the anterior capsula, which are the 1, 2, and 3. And the glenoid labrum is an enlargement of the glenoid, which is very small. The dynamic system, which allow the humerus to relate with the glenoid are most of all dynamic. So you can see the concavity compression is performed dynamically by the rotator cuff during the movement, and the long head of the biceps has a great meaning during elevation to maintain downward the humeral head, and the deltoid, which it's a great factor of instability, not of stability, because the deltoid works against the calf, and that's why the calf need to be healthy for the shoulder to work. In the first row of the figure, you can see the capsule, which is released while the humerus is in complete adduction, and it tightens during the movement of abduction. This is, if you want, a dynamic constraint which prevent the dislocation of the shoulder during the abduction and extra rotation. The second image, you can see how the supraspinatus tendon, you can see? No, okay. The supraspinatus tendon, you can see the arrow. Vabbè, not a problem. Puntatore laser, questo qua. Okay. You can see how the head of the humerus is the main vector, which is represented by the D letter, is towards the center of the column, and it is made mainly by the supraspinatus tendon in the first 30 degrees of the abduction. In the second row, you can see the work of the internal and external rotation, which is paramount to keep the head of the humerus inside the glenoid. We talked before about deltoid. We can see here how the main vector of the deltoid in the first degree of movement during abduction is specifically upward. So the humeral head trying to translate upward instead of rotate. The mechanism which allowed the humeral head to rotate is represented by the calf. As you can see, the vector of the calf instead are pointed towards the glenoid, making the concavity compression. And as you can see, it's all about stability, because if the humeral head translates upward, it impinges with the acromion, and this provokes pain. As the same, regarding the internal external rotation, you can see that there are a couple of forces represented by infraspinatus teres minor mainly, and also other, and subscap, the upper part and the inferior part, and they are coupled to work together, and a deficiency of one of them causes the lack of that fulcrum that we talked before, and which is paramount to the humeral head to remain in his situ. This is a problem that affects very often the overhead athletes, such as volleyball players, tennis players, swimmers, also at at the highest level, such as Olympionic. I'll explain it to you after. Here we can see the scapular humerus rhythm. The scapula is not steady during the movement of abduction and elevation, but it has a precise series of movement which help the humerus to reach the upper part during abduction. It has a movement which is on the frontal plane and also on the sagittal plane. We will see it after. But it's very important. We can analyze it with inertial sensor, and that allows also to analyze the movement even, as you can see here, during the activity performed by the athlete. This is a list of the shoulder pathology that we have to see. So the most frequent, I think, in that kind of athletes is the overuse pathology. A repeated trauma, micro-trauma during training, during matches, can cause some maybe little changes in this dynamic equilibrium, which cause pain and impairment. As you can see here, this is the posterior superior impingement, which is quite frequent, most of all in baseball thrower and volleyball players. When the great tuberosity get in contact with the posterior part of the glenoid, the deeper part of the calf remain engaged between the two bony part. And you can see in the video the mechanism that is called peel-back mechanism, which has been described by Walsh, in which this mechanism of impingement causes the debris of the deeper part of the supraspinatus, and this causes pain. This is instead is the retracted posterior capsule, and is often in volleyball, is frequent in volleyball players. You can see how normally the humerus represent a concentric cycle, which has a rotation concentric to the glenoid cycle, and during the movement it has a normal laxity, normal posterior laxity, which allow the humerus to go a little back in order to get the space to have a full abduction. When the posterior capsule is retracted, you can see that there is no, this mechanism is not possible, so the humerus is pushed upward and forward, thus causing an impingement with the acromion and the spine. So we are trying to understand if it is possible to prevent this kind of injury with a study made in collaboration with an Italian volleyball team. They are the Italian champions of Macerata. The rationale is that repeated gesture of smashing can cause a retraction of the posterior capsule and consequent anterior pain. The hypothesis is that preventing therapeutic exercise for elasticity of the posterior capsule can prevent this kind of retraction. Maybe a dynamic MRI can describe, well, Professor Monetti, we will see it after this presentation, adding the dynamic MRI to test the difference with and without the therapeutic exercise could be very interesting. We are very interested in the field of the posterior instability. We say that it is our main field of research, and you can see that is the test for testing the posterior instability made by Professor Porcellini. Usually you can see a posterior labrum tear, which is obviously you can see it also in a static MRI, but not often, not always. Sometimes there is only a micro instability which generate no labral tears. So in a static MRI you can see it, you cannot see it. This in the video is a positional dislocation of the shoulder. You can see the right shoulder. The patient is able to regain relocation of the shoulder, and is due probably to the activation of the latissimus dorsi, which has a mistaken activation. We are studying it with kinematic analysis and dynamic MRI and electromyographic evaluation to see if these three kind of imaging system, analytic system are in agreement, all the three, to detect this activation of the latissimus dorsi. One thing that we have to consider, and this is important, is that laxity is different from instability, because many patients, most of all Olympionic athletes, which has a laxity which is not normal, is often more than the normal people. Laxity is not a problem, does not cause a impairment of the function. So we have to be serious to select what is a laxity, what is an instability. A laxity does not give pain, while instability gives pain. So, and another things to detect is the voluntary dislocation. Often in young girls, maybe 16, 18, there is a tendency to have a voluntary dislocation, most of all caused by psychological problem often, and we have to see also that there is a moment in which they reach the dislocation voluntary, and that's laxity versus instability is an example of how the radiologists have to play in the same team of the orthopedics, because you cannot ask a radiologist to assess a problem, an issue, a lesion, if you don't give him the clinical information, especially in a dynamic MRI, which requires a lot of time to see everything. You have to ask a very precise question to the radiology, which very precise could answer. So another field in which we intend to use the dynamic MRI is the detection of the track which the Hill-Sachs lesion on the posterior aspect of the humeral head, if this posterior lesion will engage with the anterior portion of the glenoid. So how you can establish if this damaged area will stay inside the glenoid or outside the glenoid, especially when you have a bipolar lesion. Actually, you can only perform a mathematical method calculating the area of both the glenoid defect and the humeral defect, but it's not so precise. If you have a dynamic system that can watch if there is an engagement of the two lesions, it could be interesting to see it. And so another application could be the evaluation of the tendon transfer. We perform a muscular transfer in order to regain a function that is lost. For example, in a subscapularis lesion, you can use pectoralis minus transfer, or in a posterior superior calf lesion, you can use a latissimus dorsi transfer. But sometimes they have some problems. So patient does not regain stability or does not regain the strength that he had before. So you can, it could be interesting to see if the transfer works or not, and why. Maybe there is an impingement. When you perform a transfer, you have to do a specific pathway between the, for example, the latissimus dorsi. You have to pass between the teres minor and the deltoid, and it's not so often often it's not so simple to identify both the muscles. So it could happen that you perform a wrong surgery, but with a dynamic evaluation system, you can maybe understand what's the mistake. And another field which is of particular interest for our orthopedic is that when you have to decide, you have an older guys with arthritis, concentric arthritis, not a clear calf lesion. If it is a calf tear arthropathy, you have no problem. You can go for the reverse prosthesis, for sure. But in this case, when the patient maybe has got, is 50 years old, it has a great arthrosis, but concentric, and you cannot make any mistake in calf evaluation, because if you go for the anatomic prosthesis and the calf doesn't work, it is a great mistake, and the patient has to undergo another surgery, and it is difficult to explain to him what has gone wrong. But often, when you have this type of arthritis, the shoulder is not moving. It's fixed, almost fixed. And so how do you evaluate the rotator cuff? A dynamic system with which you can analyze the muscular movement during abduction or flexion or rotation could be very useful for us, and could save a lot of poor shoulder that otherwise will underwent reverse shoulder arthroplasty, which now is the tendency, but is the tendency because we are not well aware of how the calf function in these cases. Another field of application could be the evaluation in the reverse shoulder arthroplasty of eventual impingement that could occur during the movement. As you can see, this is predicting 3D imaging, which allow us to understand if there could be a bone impingement, but shoulder is not made only by bone, is made most of all by soft tissue. So we need a methodic which can investigate the soft tissue and investigate if there is or there isn't a potential impingement during the movement. Sometimes you cannot understand why this reverse prosthesis gone wrong, and you have the suspect that it could be an impingement, most of all in an anterior impingement during interrotation with the coracoid. It's the one that that is most difficult to see, but I think that it is the problem of a lot of reverse prosthesis. So even in this field, a dynamic system could be helpful. And I terminate with talking about the scapular humerus rhythm. You know that the scapula is going laterally, with the inferior angle of the scapula going laterally during abduction, and most of all there is a tilting, because usually the scapula is in a protraction position, while in the last 20-30 degrees of the abduction, there is a posterior tilt which allowed the humerus to get free and do not impinge to the acromion. And this is difficult to understand even in a clinical situation. You can have you have some tests, you have some suspect, but you are not fully aware of the movement of the scapula. So even a dynamic MRI could, even if it is difficult to search for the scapula during an MRI, and could give us the information to understand the pathology of the scapular rhythm. And the last, the preoperative planning in an RSA, we are a lot precise using this 3D imaging software, which allow us to reconstruct a scapular model and the humeral model, but we consider the scapula as it is always stick orthogonal to the basement. So it is difficult that the scapula, most often when you have 80 years, it is protracted and recurved. So it should be interesting to understand the position of the scapula in the space during the movement in order to perform a realistic project of your RSA. So, shoulder is the joint which most is interested by a dynamic mechanism. Scapular is an unexplored word and should be investigated in a standing position during movement. So dynamic MRI could definitely help surgeon to understand both the pathologies of the glenohumeral and the scapular. I thank you and invite you all to our congress, which is Cutting Edge Techniques and Controversies, which we perform together with Professor John Sperling of the Minnesota University. Thank you very much.
Thanks a lot, Andrea. So very important to show how the clinician needs to see not a static imaging, but a dynamic imaging, mainly as we have seen in an anatomy very particular for biomechanical point of view, like the shoulder. So thanks a lot, very important indication. So it's time to honor you also, please. So please stay here. I kindly ask to Professor Majan, Rachel, and Professor Monetti that is trying to set up his computer for the next presentation to honor Andrea Giorgini for your great talk. Thanks.
Thanks a lot. Perché ci mette un po'.
Così non cade.
Thanks. Okay, so now we move to the last presentation that is linked to the presentation of Andrea Giorgini, because they are working together with the team of Professor Porcellini, with Professor Monetti, in order to make important result on dynamic imaging. So, Professor Monetti will speak in Italian, so I will translate for him. So, be patient if I can make some mistake. I'm not a doctor, but I will try to do my best. Thanks.
Non ci sono le relazioni, adesso andate a finire.
No, guarda se qua sotto
nascosto. No, questo non c'entra niente.
Tiralo su.
L'ho tolto io, no.
Ah.
Cioè, le ho tutte sullo schermo. Cioè,
non c'è
prima
niente.
che l'avevo aperto, infatti. Perché è successo?
Prova a riavviare. I cannot see the...
Ragazzi, cominciare bene.
Ah, c'erano.
C'erano, aspetta.
Vabbè, secondo me se lo riavvii... just a second, after.
No, adesso lo spegniamo perché se dobbiamo metterlo quando lui è spento, se no...
Secondo me sai cosa facciamo? Quando tu lo riavvii, lanci la presentazione e poi colleghiamo, perché ti ha fatto sparire le applicazioni, il collegamento, secondo me.
No, perché quando io lo collego dopo non partono i filmati.
Ah, allora è meglio
attaccarlo?
prima?
Sì.
So please.
Ok.
No?
Però prima era andato, cioè abbiamo provato, scusa.
Non ti preoccupare, stavo in casa, spero.
Speriamo.
Vuoi che mi metto qua vicino o mi
Sì,
guardi? Se no io mi mettevo lì. Okay, so we can start.
Good afternoon, everyone. A special thank for my friend Arsh for this kind invitation to the Congress. I apologize, my poor English, my lecture is in Italian language. Innanzitutto un saluto da Bologna, che come penso tutti sappiate è l'università più antica del mondo, soprattutto per la facoltà di medicina, e nacque nel 1113. Queste sono le varie collaborazioni che sapete che abbiamo con tanti gruppi, e direi non è tanto per farsi belli del fatto di con chi collaboro, quanto che per un radiologo è importantissimo, quando facciamo diagnosi, avere un riscontro di quello che poi abbiamo visto. Con gli atleti il riscontro l'abbiamo sempre, perché sappiamo sempre quello che è successo.
Okay, here all the center and the team with which Dr. Monetti collaborates.
Storia degli Esaote è già stata detta, fin dal 1982 cominciamo con l'Artoscan per arrivare all'E-scan e al G-scan, e quest'ultimo appunto che è il Magnifico, che è una macchina che ci consente di fare non l'ortostatismo, ma è molto ampia, per cui ci consente comunque una notevole panoramicità. Come vedete abbiamo una scuola che nacque con un discorso con Arsh a Firenze nel 2011 e la continuiamo, è importantissima la scuola soprattutto per radiologi, ma soprattutto per i tecnici, come vedremo successivamente.
So, Professor Monetti start with us with the first machine 1992 Artoscan, and then moved to the other system, and is just underlining that use all the MRI machine from Artoscan to the latest one that is just trying in Esaote factory, the Magnifico, and he just underlined the school that he start together in collaboration in Florence with Majan, that is a school that organizes courses for weight-bearing MRI user.
Già con le prime macchine del 2004, con la prima macchina degli G-scan, cominciamo a fare gli studi con l'Istituto di Ingegneria Biomeccanica per dimostrare appunto che la tomografia computerizzata e le macchine ad alto campo di risonanza magnetica erano comparabilissime a questa macchina, e i risultati sono sempre stati molto positivi.
Okay, mention to the studies they do with biomechanical engineer to optimize this type of application in dynamic, which is nothing more than a recording movement of the joint inside the coil.
Quello che molti medici non sanno, e alcune volte anche il radiologo non ne ha conoscenza, del discorso della differenza fra la CNRM e la dinamica. Come vedete la CNRM sappiamo perfettamente che è un cartone animato per cui sono tanti frame messi in sequenza. La dinamica è effettivamente un esame dinamico nel movimento fatto fare al paziente nei vari movimenti necessari.
First of all, we need to distinguish between cine MRI and dynamic MRI. As you can see in the previous slide, on the left there was an image that looks like a cartoon, and on the right there was visible the real dynamic imaging, just to distinguish the two different investigations.
Gli ingegneri hanno sempre criticato noi medici perché parliamo di esami dinamici quando in realtà sono esami funzionali. La radiografia nelle varie proiezioni, in flessione, in estensione, anche la risonanza magnetica, inclino e in ortostatismo in realtà sono esami funzionali, non sono dinamici. La dinamica parla da sola come termine, deve essere in movimento.
Here we are talking about functional examination, which is not a dynamic examination, but is what you carry out in various positions, such as a supine patient and a patient under physiological load, as you can see on our right. And here it can already be seen on how the result could change in terms of images on the same patients in different positions.
Come vedete gli esami dinamici possono essere effettuati in tutte le articolazioni e nella colonna, come abbiamo già visto anche nelle precedenti relazioni, e giustamente poter sfruttare su indicazione ovviamente dei chirurghi di quello che è il sospetto clinico i vari movimenti per esacerbare e poter vedere meglio la patologia.
So here it's important to underline the dynamic imaging MRI, so we can see how also the structure of soft tissue can change and can be moved.
Se ne è già parlato nella mattinata, reputo che sia importantissimo innanzitutto che la scelta della metodica sia del radiologo. Tante volte noi in Italia, io spero che non sia così anche da voi, ma penso che sia in tutto il mondo, siamo, non dico costretti, ma ci impongono quasi la scelta della macchina. La scelta della macchina deve essere radiologica. Il basso campo e l'alto campo hanno delle peculiarità, sia le une che le altre. Ovviamente, come è stato detto anche stamattina, l'alto campo sicuramente per l'encefalo, per alcune patologie particolari è la macchina da utilizzare in assoluto, ma il basso campo ha il vantaggio, come appunto vediamo, di poter fare clinio e ortostatismo e soprattutto la dinamica. Dinamica in che termini? Io per dire che questa macchina tiene la strada la devo guidare, la devo vedere girare e non posso dire in una fotografia statica se quella macchina si comporta bene.
So another important aspect to consider, we have seen in previous presentation this morning, to distinguish the high field and the low field, obviously, but Professor Monetti would like first to underline that the non-radiologists, we should say, should not ask on which machine you need to do the MRI. That it's an important point, because this should be, after the indication of the clinician, a decision from the radiologist that know this kind of technology.
Faccio una piccola virgola in questo discorso,
Yes.
nel senso che, come vedete, queste sono immagini fatte in dinamica con macchina ad alto campo. Non è tanto il macchinario che dobbiamo scegliere, sicuramente la macchina a basso campo e l'apertura del magnete ci consente tante dinamiche in più, ma come al solito io dico l'importante è il pilota. Il pilota deve avere l'esperienza, il tecnico altrettanto, e come vedremo appunto adesso la collaborazione con i vari gruppi, cioè è fondamentale il lavoro d'equipe, ortopedico, radiologo, paziente, i nostri tecnici, l'equipe dei tecnici deve essere bravissima, la collaborazione col paziente stesso, un'anamnesi corretta, l'impiego eventuale di device e soprattutto, come dico spesso, la possibilità di collaborazione con il chirurgo. Per noi è fondamentale sapere che tipo di intervento è stato fatto, perché molto spesso siamo sottoposti a fare diagnosi su esami nei quali non conosciamo le problematiche dell'intervento, per cui l'esame risulta quasi inutile molto spesso.
Yeah, here Professor Monetti want to underline the collaboration. Obviously, we should have with the orthopedist or clinician that give us information on what was done. For example, as in this case, during a surgery. And this is important for Professor Monetti to show in a proper way the dynamic imaging. So it's important that clinician and radiologist speak and speak together.
Va sottolineata l'importanza che l'esame dinamico è un esame estremamente impegnativo per il tecnico per primo, ma anche per il medico quando deve fare la lettura dell'indagine. È praticamente un equilibrista, nel senso che mentre una ATC fa un esame volumetrico di tutta l'articolazione, vedete che noi qui per vedere questo tendine andiamo a fare un taglio mirato sul tendine, per cui molto spesso un tendine d'Achille che è rettilineo è facile seguirlo, un tendine che è curvilineo diventa più impegnativo, per cui sicuramente è un esame impegnativo sia da un punto di esecuzione tecnica che successiva lettura di chi va a fare il referto.
So here is to demonstrate that the dynamic are images made on a treat, like the man you can see in the center, in the sense that it is not like easier like a 3D CT, that you just push a button and you do it. Here you have just one cut in the dynamic imaging, so you need to have more information for the clinician in order for the operator to perform the best dynamic imaging, cutting in a proper way the ligament or the tendon, as Dr. Monetti showed here in the ankle image.
Qui iniziamo con la spalla e mi riferisco a quanto ha detto
Shoulder.
prima Andrea Giorgini, del fatto appunto di conoscere molto bene la funzione dei muscoli, la funzione dei legamenti, la biomeccanica è fondamentale per poter capire la situazione. Guardate questo esame, lo stesso paziente, se noi facciamo una risonanza statica, abbiamo un piano di clivaggio nel quale diremmo che non c'è impingement. Guardate lo stesso paziente, sappiamo da studi di biomeccanica che i fasci anteriori del muscolo deltoide sono quelli che trazionano verso il basso l'acromion e vedete che nella dinamica dimostriamo esattamente che c'è un impingement che nell'indagine statica non risulterebbe esserci.
Yeah, this is an important and real advantage of dynamic imaging because on the right you can see how in static image we often do not see the impingement. Then on the left you can see very well in the dynamic examination the impingement.
Altrettanto una lesione sospetta clinicamente dal professor Porcellini della cuffia, stesso paziente, l'esame statico non evidenziava la lesione. Come vedete, dando 4 kg di peso al paziente e facendo la dinamica in intra ed extra rotazione, riusciamo a evidenziare perfettamente la lesione che clinicamente si sospettava.
Again here we can see how in the static image on the left we cannot see the lesion that we can see under load with patient seated inside the machine with a weight of 4 kg and also with the dynamic imaging. So completely change the answer and the diagnosis report.
Le slap lesion sono situazioni, come tutti conosciamo, di lesioni di disinserzione delle cerci nel fibrocartilagino del capolungo del bicipite. Sicuramente l'Arthro RM fino ad oggi è stato il gold standard, ma quando abbiamo cominciato gli studi con la risonanza, con il G-scan, soprattutto in ortostatismo e dando dai 3 ai 5 kg di peso, come vedete senza il peso la slap sembra negativa, con il peso riusciamo a distaccare il cercine e dimostrare la lesione. In più abbiamo la possibilità di eventualmente fare l'esame dinamico, che è un aiuto ulteriore.
So still in the slab lesion, being a detachment from the traction of the tendon by placing the patients under load with a weight of 3-5 kg. Let's see how the detachment open Tasperaf avoiding doing, for example, an MR arthro. So sometimes the problem can already be solved with the patients in weight bearing.
Questo è uno dei casi di cui parlava prima Andrea, la ricostruzione del gran dorsale che con Porcellini costantemente controlliamo. Sappiamo che il gran dorsale è un muscolo intrarotatore che deve essere successivamente adattato a tornare a fare la funzione di extrarotatore. Sicuramente con l'esame dinamico e anche molto con l'indagine ecografica, con l'elastografia, siamo in grado di dare un'ottima valutazione del momento in cui il chirurgo giustamente può sottoporre il paziente a una importante fisioterapia rieducativa.
Yeah, here, as underlined before by Andrea and the team of Porcellini, it's important the large dorsal muscle on shoulder, and here we can see a patient after surgery, and in dynamic we can see how the new postoperative tendons works.
Ancora con il gruppo di Porcellini forse siamo stati i primi al mondo a fare lo studio ecografico dinamico con l'elastografia e con la dinamica di risonanza magnetica nella augmentation della cuffia dei rotatori rotta nel giovane, nella quale viene inserito un patch dermico che nel tempo deve maturare e diventare tendine, per cui giustamente a distanza di 3 e 6 mesi facciamo i controlli per fare una valutazione dinamica per vedere quanto il materiale è omogenizzato col tendine.
Yeah, in this case the elastography also is very important, but also obviously together with the dynamics where we can appreciate the layer of regenerated tissue that become a tendon after surgery.
Negli conflitti dell'impingement coracoideo, come vediamo in statica molte volte lo spazio coracotrochinico, che deve essere normale a questo livello, non diminuisce nell'indagine statica. Lo stesso paziente portato in dinamica, vedete come chiude completamente lo spazio coraco-troclinico per un'instabilità anteriore di spalla, microinstabilità che clinicamente non era valutabile. Per cui vedete come la dinamica fa vedere perfettamente un quadro che è sicuramente chirurgico e che può portare poi nel tempo, se non trattato, a una lesione completa del tendine sottoscapolare.
So here they confirm the suspect that they have clinically about this instability. As you can see here, the impingement and the reduction of the space in the subscapularis can be seen in the dynamics, while in the static it seems very normal.
Questo è un quadro al quale sono molto affezionato e Porcellini altrettanto, importante atleta di football americano che si presenta con un dolore alla spalla destra e una marcata ipotrofia del deltoide nei suoi fasci anteriori. Nell'esame statico non riuscivamo a definire le problematiche perché non c'era un dato, un elemento così evidente da poterlo pensare. In dinamica ci rendiamo conto. Sappiamo innanzitutto che il deltoide nei fasci anteriori è innervato dal nervo ascellare e in realtà vediamo il nervo ascellare a questo punto che è completamente strangolato dal sottoscapolare e dal coraco brachiale ipertrofici in un atleta con una muscolatura importante.
Here we have a rugby player with, on the right we see the patient with 1.5 Tesla in static image, the possibility of doing all the functional and above all the dynamics made him understand that it is a hypertrophy of the deltoid in the anterior side, and we can also appreciate the compression of the axillary nerve in the dynamic image.
Questi sono i casi che ha fatto vedere prima Andrea, giustamente le microinstabilità, come dicono gli ortopedici, Porcellini lo dice tutti i giorni, le microinstabilità sia anteriori che posteriori sono clinicamente difficili da rilevare e nell'indagine statica non diremo mai che queste spalle sono instabili perché sembrano perfettamente stabilizzate. Ma ancora di più importante la possibilità di fare una valutazione dinamica a questo livello perché il paziente, che è un noto cantante italiano, con una lesione completa di cuffia, vedete che comunque ha una stabilità perfetta data da una buona muscolatura sia dei muscoli anteriori che posteriori, che consente una regolare stabilità, perché giustamente Porcellini dice di fronte a una situazione come questa non faccio l'intervento. Per cui vedete che la dinamica ci aiuta non solo nella scelta dell'intervento, ma tante volte nella esclusione di un intervento che andrebbe evitato.
Yeah, here is an important example of conservative treatment follow-up for the patients, because on the left, obviously, we can see a dynamic dislocation anteriorly, and on the right, dynamic dislocation posteriorly, that we cannot see in the static. But the most important thing is the image on the center that show that there is not too much dislocation. The muscle, both anteriorly and posteriorly, are working well. And so the shoulder turn perfect, as you can see, and therefore here the orthopedic surgeon decided not to operate.
Qui direi il caso che ha fatto innamorare il nostro amico Giovanni Di Giacomo, che è stato quello che forse è stato il primo a parlare di on track e off track, e come vediamo nella dinamica la risonanza magnetica è in grado di far vedere in una lussazione di spalla in cui avevamo una lesione importante di Sachs dimostrata anche dall'alto campo e dalla ricostruzione TC, ma soprattutto vedere appunto la lesione off track con la lesione bipolare e la testa della posteriore della glena, dell'omero che arriva a sbattere con la parte anteriore della glena, cosa impossibile da diagnosticare ovviamente in un esame statico.
So this is an important case that has been well noted also from a famous orthopedic surgeon. Is a well-known orthopedic surgeon worldwide that collaborate with Professor Monetti, and here we can really appreciate the off-track lesion thanks to the dynamic imaging on different positions.
Molto spesso e l'ortopedico, Porcellini ce ne chiede spessissimo, controlli in fratture non viste all'indagine radiografica, ovviamente viste successivamente alla risonanza magnetica, con il placet dell'ortopedico che dice sì, possiamo tentare di fare la dinamica per vedere se la frattura è stabile, ne facciamo e direi molto spesso vediamo perfettamente stabili, ma capita anche di vedere delle instabilità di fratture che giustamente vanno trattate in altra maniera.
Yeah, here an example of fracture not seen in the emergency room hospital. After some time with the dynamic, we are being able to see not only the fracture, but to tell the orthopedist that the fracture is stable.
Ancora, paziente operato, molto spesso la richiesta nel sospetto clinico che la placca vada a urtare contro l'acromion, nell'esame statico è impossibile poterlo definire. Come vedete l'esame dinamico dimostra perfettamente l'urto completo della placca, che poi è stata rimossa, con l'acromion, per cui vedete che con sequenze idonee anche con i mezzi di sintesi l'artefatto viene molto ridotto e la risonanza anche in dinamica ci consente perfettamente la diagnosi.
Yeah, here first of all I would like to underline how we can reduce the metal artifact due to the fact that we have a specific sequence and also due to the fact that it's a low Tesla machine. But in this important case we can appreciate the orthopedic clinical suspect that was that the irons collided with the acromion. So he removed the plate and on the left the screw and remove also maintain the screw, and so in the movement we can see that solved the problem.
Ne parlava prima Andrea delle protesi, sappiamo che nell'emiartroplastica il motore è la protesi, sappiamo altrettanto che nella protesi inversa il motore è il deltoide. L'importanza non è la bellezza dell'immagine, giustamente Porcellini dice a me serve capire quanto quel muscolo sia funzionale. Questo è un ragazzo di 28 anni con un deltoide quasi atrofico, questa è una signora di 74 anni che con la protesi inversa fa funzionare molto bene il deltoide, per cui vedete appunto l'utilità della dinamica in questo senso.
So here again, two patients with prosthesis. On the left we have a young patient, 20 years old, and on the right we have a older patient, 74 years old. But in general, here Professor Monetti wants to underline that sometimes the image must not be so beautiful. It's important, like in this case, how we can appreciate how the muscle, deltoid muscle, is still working. And this is an important indication for the clinician.
Altra situazione molto importante è l'elastofibroma del dorso, lesione fibrolipomatosa molto frequente a livello retroscapolare, e in questo caso direi la dinamica è importantissima perché molto spesso l'intervento viene fatto in associazione fra ortopedico, neurochirurgo e chirurgo toracico per la posizione molto vicina ai nervi intercostali e alla pleura, per cui interventi estremamente delicati. Per il chirurgo è fondamentale sapere che ci sia un buon piano di clivaggio perché può sgusciare dall'esterno la lesione senza andare a rischiare di fare dei danni in strutture molto più importanti.
Yeah, here is a very particular case, but the dynamics allow to the surgeon to say by looking at this benign lesion near the pleura of the chest wall, to remove it, you must find an entrance that cannot damage, for example, nerve structure of the pleura, which are very delicate. So here is important for the surgeon to understand how to make the intervention.
Molto importante riuscire a fare diagnosi corretta anche a livello delle regioni del plesso brachiale. Questo è un caso borderline ortopedico che va a operare giustamente un esito di frattura della clavicola a livello dell'inserzione sternale e ci chiede dopo l'intervento per reinserimento dello sternocleidomastoideo se in realtà il muscolo e l'articolazione tornano ad avere una buona funzionalità e come vedete direi perfetta.
Okay, here is a brachial plexus case, and we can see the reconstruction of a fracture done by a surgeon of the external clavicle joint. And thanks to the dynamic, we are able, after surgery, to see how the muscle works correctly, and the dynamic confirms it. post-operative. Elbow.
Elbow, nella lesione dei legamenti, come vediamo, la risonanza statica molto spesso pone diagnosi di lesione, ma non completa. Guardate come nella dinamica vediamo che il legamento è marcatamente slargato e completamente stirato, si è creata proprio una lassità importante e soprattutto guardate come in dinamica molto spesso riusciamo a dimostrare l'edema spongioso da sovraccarico che avviene nel movimento, che poi molto spesso causa di dolore importante.
So here again the static image not put in evidence the lesion that you can see in the dynamic image, and that also show the edema of the bone spongy and therefore show also a compression edema during the movement that we can note.
Ancora la statica può porre il sospetto di lesione capsula legamentosa, ma come vedete in dinamica abbiamo una lussazione quasi completa, per cui non solo da un punto di vista clinico ma anche da un punto di vista medico-legale reputo che sia molto importante dimostrare queste lesioni.
Yeah, again here another cases of dynamic imaging where also it's very important a legal aspect to take in consideration for this lesion.
Due casi borderline del gomito, in questo caso una lesione fratturativa pluriframmentata dell'ulna. Ho messo il paragone del punto d'angolo posteriore interno del ginocchio con il gomito perché l'anatomia è molto simile a questo livello. Quello che interessava sapere Porcellini era la possibilità di capire se in realtà c'era una lassità capsula legamentosa che clinicamente non era facile perché era un gomito estremamente rigido. In effetti, in dinamica, la dimostrazione è perfettamente del legamento collaterale ulnare del radio che è completamente lesionato, consente la rotazione interna dell'articolazione.
Here, Professor Monetti want to underline how, in some cases, knee joint and elbow joint has a similar functionality. And here, obviously, we can see our machine can reduce metallic artifact. And in this case, thanks to the dynamics, we can see the opening of the posterior internal corner point, which is not visible in the central image, that is the static one.
Altro caso nel quale con fratture multiple la TC nella ricostruzione tridimensionale, ma altrettanto la risonanza, non consentivano di porre una diagnosi corretta e concreta. Quello che interessava a Porcellini era sapere se tutti questi corpi articolari mobili calcifici fossero la causa di blocco meccanico e in realtà la dinamica è l'unica indagine che riesce a dimostrare che tutte queste immagini a bassa intensità di segnale sono in realtà le calcificazioni che si interpongono sulle facce articolari e vanno a creare il blocco.
Allora, here we have a case of multiple fracture and we can see how CT, X-ray and static MRI make a difficult diagnosis, which interests what the surgeon was looking for was the calcification, so what happened. And in dynamics, we can appreciate the cause of impingement, inflection, extension, and therefore by removing this calcification, he has solved the problem. Wrist.
Ancora un caso nel quale nella statica possiamo solo sospettare clinicamente che ci sia un'instabilità. Come vedete l'instabilità è quasi completa, una sublussazione dell'ulna per lesione del legamento radioulnare distale ventrale quasi completa.
So here we can really appreciate from static to dynamic the dislocation of the ulna.
Altro caso molto importante, sappiamo come nel polso il legamento scafo-lunato dorsale sia il legamento che costituisce la stabilità di tutto il nostro polso. Molto spesso nella statica non riusciamo a dimostrare quelle lesioni e quell'apertura, quella dissociazione scafo-lunata che è data proprio dalla lesione di questo legamento, che per il chirurgo della mano è fondamentale da sapere.
Scapholunate ligament, very important for wrist. Let's see how it opens in dynamic compared to the static. So we can see that is damage.
Lesione che poi comporterà un andamento in disi, cioè dorsiflessione del semilunare, che comporta successivamente poi un impingement causa del tunnel carpale per compressione del nervo mediano dato dalla filiera a questo livello.
Okay, here we can appreciate for dynamic compression of the carpal nerve in the carpal tunnel area.
A livello delle dita, questo è un dito normalissimo, molto spesso, soprattutto dopo un intervento, abbiamo dei blocchi meccanici e vedete come la risonanza in dinamica dimostri che c'è, nonostante l'intervento, c'è una sublussazione della falange prossimale sulla testa del metacarpo a questo livello.
Yeah, here is very evident moving to finger how on the left there is a normal situation and on the right you can see this location that create a subluxation on the finger. Very evident. Move to hip.
Molto spesso diamo degli impingement femoroacetabolari, cam o pincer, su un'immagine statica che poi non ha un corrispettivo reale. Sicuramente l'ARTO-RM è un'indagine molto importante, ma nella dinamica siamo in grado di vedere perfettamente quando un cam va a determinare una compressione diretta sul cercine fibrocartilagineo e dare un impingement in dinamica. Sicuramente direi è un esame che nella dinamica vale moltissimo e con la nuova macchina, col Magnifico, abbiamo un campo ancora più ampio che ci consente sicuramente dei movimenti più completi per poter dimostrare direttamente l'impingement a questo livello.
Yeah, here again, as we have seen in the shoulder, also the hip, it's very important in the dynamic imaging to understand impingement or not impingement. And previously we have seen from static to dynamic the evidence of the impingement. And Professor Monetti underlined also the new MRI developed by Esaote, the name is Magnifico, is a 0.4 Tesla, that has obviously more SNR and more homogeneity field of view. And for this type of examination like hip, you have obviously more information around the joint. And here we can appreciate it was a cell phone picture, but explain well the result.
Ancora a livello dell'anca, situazioni nelle quali molto spesso la clinica non riesce a porre diagnosi, molto spesso noi radiologi sulle immagini statiche non riusciamo, l'impingement della sindrome del muscolo piriforme che crea compressione sul nervo ischiatico e ancora di più, molto più frequente ma meno conosciuta, la sindrome del muscolo quadrato del femore. Come vedete il muscolo quando è ipertrofico, contraendosi, va a comprimere perfettamente il decorso del nervo ischiatico, mimando molto spesso delle ernie del disco che non vengono riconosciute nella maniera corretta.
So on the hip anatomy, it's also important to evaluate the muscle. And previously we have seen how the piriformis muscle it works, and also at the femoral level, as you can see here, it's important to know the movement and how it works the muscle.
Ancora studio dinamico delle protesi, giustamente per l'ortopedico non è tanto la qualità dell'immagine quanto la congruenza nei movimenti della protesi con l'articolazione. In questo caso analogo a quello che avevamo visto sulla spalla, il sospetto del clinico, del chirurgo, era che la vite debordasse dalla testa del femore, come in realtà succede, e vedete che nonostante modesti artefatti creati dai mezzi di sintesi, l'esame dinamico riesce perfettamente a dimostrare la lesione.
So here again we have an important case with a screw, and obviously Professor Monetti underlined again the importance to using low field and not in the 1.5T, and also is going to show that in dynamic imaging you can simulate the real situation and it shows the impingement on the screw that needs to be removed. Move to knee.
Sul ginocchio conosciamo tutte le problematiche dei legamenti crociati. Il crociato è un elastico. Se noi facciamo una diagnosi in un paziente sdraiato che non muove il ginocchio, non è in carico, molto spesso diamo dei crociati che sembrano normali e che normali non sono. La diagnosi di crociato è una diagnosi clinica, funzionale, assolutamente dinamica. Non possiamo dire che questo elastico è normale perché l'abbiamo fotografato su un tavolo. Per dire se questo elastico tiene o meno, dobbiamo metterlo sotto stress. E come vedete già l'esame ortostatico dimostra che lo stesso paziente ha sicuramente delle problematiche importanti perché sotto carico questo crociato deflette marcatamente. Ma soprattutto è l'esame dinamico. Vedete che il crociato quasi scompare completamente e abbiamo una traslazione anteriore dell'asse tibiale rispetto al femore, classico segno del cassetto che sta a indicare una netta insufficienza del crociato rotto.
So here is very important ligaments because we have to consider they are like elastic bands. So if I take a picture on an elastic band on a table, I could tell it's good. But if I have to see it under extension or traction, I can have a different scenario. And also, as you can see and appreciate here, the weight bearing always already show a different clinical picture, which is confirmed even more with the dynamic imaging. So it's important to understand this because sometimes in conventional examination, without movement, without weight bearing, we can have some mistake in terms of diagnosis.
Lo stesso concetto è applicabile ovviamente nei controlli di crociati operati. Questo è il professor Lelli, che è stato uno dei primissimi ortopedici a credere in questa metodica. Ha un test chiamato test di Lelli, col quale vediamo appunto se c'è una possibilità di capire clinicamente l'instabilità, ma sicuramente oggi è un fautore assolutamente di quello che è l'utilità della risonanza, perché possiamo vedere un'infinità di situazioni, dalle recidive di lesione a un legamento che può essere lasso o quant'altro, per cui poter fare diagnosi. Stesso discorso fatto per i crociati anteriori vale esattamente per un crociato posteriore. Direi nel crociato posteriore aprire attenzione a una piccola lucina, molto spesso non teniamo conto che in un cassetto posteriore ci sono lesioni vascolari che molto spesso non andiamo a valutare, per cui ricordiamoci di valutarle ovviamente quantomeno con un'ecografia con il Doppler.
So same concept we have seen at the beginning is also as seen with surgery knee patients, where it's very important. He showed a clinician that simulate the movement he need to understand to confirm the clinical suspect. And here also we can also think about the same for posterior ligament. Not only for the cruciate ligament, and also for the collateral ligament, as we can see
Stesso
here.
concetto con il collaterale laterale, con il punto d'angolo poster esterno, e altrettanto con il collaterale mediale a livello del punto d'angolo poster interno. Tutte situazioni che nella dinamica ci fanno vedere la reale situazione e il reale grado di instabilità.
So here we can see how the dynamic really show us the real situation you can find inside the knee.
Sui menischi abbiamo fatto fin dagli inizi uno studio con la biomeccanica, con l'ingegneria biomeccanica. Sappiamo perfettamente dall'anatomia che il menisco mediale è ancorato alla capsula, per cui ha un movimento molto limitato rispetto a quello che è il movimento del menisco laterale, che è libero, per cui ha una maggiore escursione. E tutti gli studi fatti con la risonanza dinamica e con la bioingegneria hanno corrisposto perfettamente nelle misurazioni. Questo è un concetto molto importante perché ci ha consentito di traslarlo ovviamente nella patologia. Come vediamo, guardate come nella dinamica un menisco che è instabile tante volte crea un blocco meccanico che può mimare clinicamente il manico di secchio, che un manico di secchio non è, squisitamente perché è un menisco instabile. Come vedete, fra l'altro, la compressione in dinamica fa vedere appunto l'edema osseo che avviene proprio nel movimento ed è causa di dolore.
We then move on the menisci that, as you know, are mobile, and therefore dynamics here it's really important, as already Professor Monetti showed in the previous slides. Obviously here in the static image, menisci seems almost normal, but in dynamic are not, because as you can appreciate, the menisc can dislocate, extrude.
Provo a accelerare un po', se no li addormentiamo tutti.
Va bene. Dimmi tu quando.
Come vedete, è stato visto anche nelle immagini nelle relazioni precedenti, un menisco operato dal clino all'ortostatismo tende a divaricare un minimo, ma in realtà non è questa la stabilità del menisco operato quanto questa. Vedete come tante volte nell'immagine, anche in ortostatismo, ma statica, non riusciamo a capire realmente la posizione di questo menisco. Guardate lo stesso paziente in dinamica, guardate quanti chilometri fa quel menisco, per cui non è assolutamente stabile perché purtroppo i legamenti sono partiti completamente.
Beautiful case where we can see how dynamic can extrude the menisc that cannot seen on the static and also in weight bearing. That's very, very good cases.
Un'altra situazione molto alla quale sono affezionato è lo studio dei menischi trapiantati. Sappiamo perfettamente che il trapianto del menisco funziona relativamente e il motivo è abbastanza semplice. Questo è Pinocchio, un burattino che è condotto da dei fili. Il menisco è tenuto in sede da dei fili che sono tutti i vari legamenti, capsule meniscali. Nel momento in cui un menisco come questo si è rotto per un manico di secchio e viene ricostruito, riposizionato e fissato sul piatto tibiale, è ovvio che non ha più la funzione biomeccanica che aveva in origine, per cui non può tenere. La dimostrazione la vedete nella dinamica, in statica il menisco sembra perfettamente stabile, guardate dove va a finire e soprattutto guardate la compressione e l'edema che avviene per l'instabilità del menisco che sguscia all'esterno.
Here the similarity with Pinocchio is very beautiful. A normal meniscus is anchored by many ligaments and on the left we can see a broken menisci, is a bucket handle tear, and on the right a transplanted meniscus. But let's see in dynamic what happens when the meniscus move and goes out because the anchor are missing. And we also noticed a tibial edema that only appear under load. And this explains the similarity of the Pinocchio marionette, that is, it works if you have a string, therefore ligaments, it works, it doesn't work.
Vado rapido sulla femororotule che è già stata vedere nelle altre relazioni. Sicuramente ancora con l'aiuto dei nostri biomeccanici riusciamo a fare delle ricostruzioni anche in 3D sulla rotula, per cui fare delle valutazioni molto belle. Direi le vediamo molto bene quando andiamo a fare delle analisi, soprattutto post-chirurgiche, laddove vedete che un impingement marcato da fibrosi cicatriziale del corpo di Hoffa determina delle importanti condropatie femororotulee e anche con tendenza alla sublussazione della rotola stessa in dinamica, che molto spesso in statica non riusciamo a valutare.
So again here in important cases we can appreciate the block that occurs during the dynamics and make it clear to the surgeon if he has to do the surgery and if so what to do.
Ancora lesioni, come vediamo appunto, di una ricostruzione di un tendine rotuleo. Ovviamente il chirurgo chiede la dinamica perché staticamente potremmo pensare che questo tendine sia stabile, ma non lo possiamo dimostrare se non lo mettiamo sotto stress con una funzione in flessa estensione forzata.
Yeah. And here is very important to see how it works, the patellar tendon in dynamic that completely change the diagnosis from the static image.
Lesioni condrali, molto spesso il chirurgo giustamente ci chiede questo in tutte le articolazioni, se il frammento condrale è stabile o instabile. Nella statica il rischio di pensare che sia instabile è elevato, in questa dinamica vediamo che è perfettamente stabile. E guardate come in quest'altro caso, nella statica non riusciamo assolutamente a capire quello che avviene. Guardate il blocco meccanico che avviene, che sull'indagine statica anche minuziosamente non riusciremo a dimostrare e capire. Per cui direi per il chirurgo è molto importante sapere che cosa c'è e che cosa poter fare.
So again here there are other cases where we can have a different situation from static to dynamic image, and here we can have really important information from the surgeon to understand what he should to make surgery and what you should do in the surgery.
Ancora, come abbiamo già visto nelle altre articolazioni, la congruenza articolare, per cui al di là delle immagini artefattate, però l'importanza per il chirurgo poter capire che ci sia una congruenza regolare nei movimenti della protesi con le articolazioni.
Here we see the congruence with the prosthesis.
Sulla caviglia, rapidamente sul tendine d'Achille, come vediamo sappiamo tutti che con le macchine ad alto campo le sequenze soprattutto ad alto contrasto tendono a sovrastimare la lesione. Di fronte a un quadro come questo rischieremo di portare al tavolo operatorio il paziente. Già l'ecografia è fatta in maniera corretta, ma ancora di più la risonanza in dinamica dimostra una lesione sicuramente di alto grado, ma un tendine che è ancora perfettamente funzionante, per cui giustamente il paziente andrà al tavolo operatorio, ma con prospettive diverse.
Yeah, here we move to ankle, and Professor Moretti show how sometimes a static image from high field can overestimate the pathology on Achilles tendon. Then moving to the dynamic and obviously ultrasound image, but mainly the dynamic, we can appreciate that it not go under surgery, these patients.
Nella fascia plantare utilizziamo dei device costruiti dal mio tecnico, da Filippo, che è stato bravissimo, che mette sotto compressione la fascia plantare in ortostatismo, per cui possiamo fare delle valutazioni estremamente precise sull'elasticità o meno della nostra fascia plantare.
Yeah, here they show in the plantar fascia that they do dynamic examination thanks to the operator that is going to compress with some cushion the plantar during the flexion of the foot.
Lesione del comparto capsulo legamentoso laterale, lesione completa del peroneo astragalico anteriore, che è sempre il primo legamento che tende ad andare in rottura. Vado avanti che ne faccio vedere.
Sì.
Sempre altro paziente nel quale andiamo a fare un controllo di una lesione cicatrizzata che comunque è instabile, e lo dimostra l'apertura della pinza malleolare a questo livello, mentre in un atleta della nazionale di basket dimostriamo appunto che la lesione cicatrizzata è perfettamente stabile. Per cui vedete quanto importanza possa avere la dinamica, non solo da un punto di vista eventualmente terapeutico, ma anche medico-legale in atleti di questo rango.
And here we are going to underline how is important the legal aspect, mainly with professional athletes. Here is a basket player where the dynamic image show how is stable the ligament in the ankle.
Altrettanto rapidamente sul peroneo calcaneare, che è il secondo legamento che va in rottura, e possiamo poi passare. Molto importante la diagnosi di eventuale insufficienza o lesione completa dello spring ligament, che in condizioni statiche difficilmente riusciamo a valutare. Sicuramente nella dinamica è importante, che è poi un legamento importantissimo perché è quello che fa cadere l'arco plantare nel cosiddetto piede piatto.
The same we can appreciate is spring ligament, we feel still to the tibialis posterior, and there is no other way to see it.
Legamenti interossei, legamenti del seno del tarso. Come sappiamo, il legamento interosseo propriamente detto è quello che si oppone in massima eversione del piede, e vediamo come in realtà nella sua normale morfologia ha un'articolazione completamente chiusa. Se andiamo a vedere la lesione, guardate, sembra un crociato completamente distratto, e guardate la diastasi dell'articolazione durante il movimento di eversione forzata.
Yeah, here we have the interosseous ligament that most radiologists don't even know that exists, but it's really, really important. And here we have a similitude to the knee cruciate ligament, and we can appreciate how it's injured on the dynamic images.
Altra situazione, ostrigonum, che troppo spesso i radiologi non descrivono anche su una radiografia, e vediamo come l'ostrigonum è molto spesso causa di impingement dell'articolazione tibio-astragalica posteriore, e soprattutto impingement del passaggio del tendine flessore lungo dell'alluce, che passa proprio in questo punto e che molto spesso crea delle tenosynoviti reattive o può andare anche in rottura.
And here we can have an important impingement that we can note with dynamic imaging.
Ancora, guardate un controllo in un intervento di alluce valgo, vedete come in realtà nell'intervento vediamo che c'è una diastasi del moncone operato che non è completamente stabile, per cui sicuramente è una notizia che per il chirurgo può essere molto importante. Altra situazione che andiamo a valutare è quella della placca plantare. Sicuramente l'ecografia dinamica forse dice qualche cosa in più, perché questi sono menischi molto piccoli, ma la panoramicità della risonanza magnetica è in grado di dare delle valutazioni molto importanti in associazione all'eco.
So we appreciate also how dynamic can be very effective also in the foot and in particularly on the first part of the foot, anterior part of the foot.
Facciamo studi con il centro protesi di Vigorso, che è un centro rinomato nel mondo, anche su amputati, per cui direi è una macchina che si presta a qualsiasi tipo di studio a 360 gradi.
So here we can show how we can also make particular patients. So this machine can be used with different kind of patients like what you
E
have seen
ancora,
before.
anche sulla caviglia, la possibilità di fare appunto uno studio della congruenza articolare durante le fasi dinamiche, come abbiamo visto in tutte le altre articolazioni.
Again here with prosthesis.
Passando
Rachis.
rapidamente al rachide, qui direi c'è un po' la filosofia del G-scan. Come abbiamo detto in queste relazioni, sappiamo perfettamente che il 3 Tesla e il Tesla e mezzo sono macchine importanti, ma macchine importanti che poi in certe situazioni ci lasciano un po' a piedi. Questo paziente aveva una patologia importante del rachide cervicale e con un 3 Tesla non riusciamo a definire più di tanto. In ortostatismo vediamo già tantissimo, sicuramente con la dinamica vediamo molto di più, perché oltretutto vedete come si restringe il canale durante la dinamica, come protrudono maggiormente le ernie, per cui non devo fare un quadro di bellezza, al di là del fatto che la qualità, a mio parere, è quasi più bella della macchina piccola, ma devo fare diagnosi.
Here with the 3T, we cannot make diagnosis. Instead, with the weight bearing, with G-scan and with the dynamics information, we can appreciate the information that we cannot see on a 3 Tesla. So we are speaking about the same philosophy we discussed this morning too.
Dinamica che applichiamo a tutti i tratti, tratto cervicale, dorsale, lombosacrale, e nella dinamica riusciamo a fare degli studi molto interessanti, li abbiamo fatti con i piloti di Formula 1, per vedere appunto senza il collare di Hans, che è il collare che viene a bloccare il collo nelle vetture da corsa, e con il collare per vedere appunto il comportamento diverso della colonna quando ha un sostegno, per cui sono tutti studi che fatti sulla Formula 1 poi vengono trasportati nella quotidianità sul paziente di tutti i giorni.
Yeah, so here also we can appreciate how dynamic can be also fundamental on Formula 1 drivers test, like here we can see Alonso, and how we can report the same situation to normal patients using the dynamic MRI.
Come vedete, la dinamica in una colonna con inversione della fisiologica lordosi dimostra che le protrusioni erniarie aumentano non nella massima flessione, ma nella massima iperestensione.
Again, here we can appreciate in the dynamic that the hernia enhance not during the flexion, but during more the extension of the patient. And here we are speaking about MotoGP Dovizioso.
Ancora nella dinamica vediamo come molto spesso succede nel rachide, in statica diamo ernie centrali che non vanno a comprimere le nostre radici, guardate lo stesso paziente in un movimento di lateralizzazione come dimostra invece che l'ernia è proprio foraminale, per cui quanto cambia dalla statica alla dinamica, e la dimostrazione che molto spesso diamo negativi esami che non lo sono.
Yeah, here it's very evident in the static image the hernia is in the center, but look at the dynamic imaging how is the lateralization in the foraminal area of the hernia. Completely change the diagnosis.
Come altrettanto nello studio delle fratture, ovvio che esami come questi sono molto delicati, dobbiamo farli dopo che il neurochirurgo ci dà la possibilità di dire sì, possiamo fare una dinamica, ma poter dire che questa frattura sia stabile reputo che sia molto importante, perché TC e RM statiche fanno vedere la frattura ma non ci danno l'entità di un'eventuale instabilità. E direi la sede è importante.
Yeah, here is very important for the neurosurgeon. From the static image, we can see the problem and the instability, but in dynamic, we can really appreciate how this patient is stable after the accident. So important indication for the neurosurgeon.
Questo è un fiore all'occhiello, nel senso che io fui il primo forse a fare questi lavori sull'Arnold Chiari. Sappiamo tutti che nell'Arnold Chiari abbiamo una procidenza della tonsilla cerebellare oltre il forame manio. Sicuramente la macchina ad alto campo è importante, ma come vediamo dopo l'intervento per asportazione del peduncolo a livello dell'occipite, vediamo che molto spesso il quadro clinico non viene risolto perché è una discesa ancora maggiore delle tonsille. Vedete che la risonanza magnetica è in grado perfettamente in dinamica e con manovra di Valsalva, per cui con aumento della compressione, di dimostrare tutto ciò che in statica e a paziente in clinostatismo non siamo in grado di far vedere. Inoltre questo direi è un risultato eccellente, siamo in contatto con un neurochirurgo di New York, che fra l'altro è di origine italiana, che ci manda pazienti perché ha dimostrato appunto la possibilità di fare un ripiego, una sorta di lembo con la dura madre che sostiene la tonsilla operata in maniera tale che non aumenti la procidenza.
Okay, here we say one of the first cases, Monetti start to work with Arnold Chiari, so here there is a lot to talk about, but here we can see how the tonsil go down with patients under load, for example.
Direi che con gli studi che abbiamo fatto, perché abbiamo fatto moltissimi casi, siamo arrivati a dimostrare con alcuni neurochirurghi australiani che sostengono che la iperprolatinemia nelle pazienti giovani in cui c'è il sospetto di adenoma della ipofisi, nei quali casi non lo troviamo quasi mai, la compressione meccanica della tonsilla sul bulbo può scatenare una iperprolatinemia, per cui a forza di farne, dopo 200-300 pazienti, siamo arrivati a queste conclusioni, direi molto importanti. Altrettanto, e questo lo salto perché lo rivedremo magari, puoi dire appunto che l'instabilità date dopo gli interventi, la colonna non consente, cioè si mobilizza o a monte o a valle, ma lo rivediamo dopo nella...
Yeah, there is another case.
Esatto.
You're right.
Ancora, il dorsale sappiamo tutti che la risonanza magnetica ha sempre avuto il problema del cuore, per cui artefatti da movimento. Guardate in questo caso una lesione vista con il 3 Tesla, con un Tesla e mezzo, nel quale diciamo che la lesione probabilmente è stabile. Guardate l'instabilità della frattura, direi abbastanza importante, per cui sicuramente la potenzialità delle metodiche di far vedere appunto la situazione reale.
Yeah, again here we can very well appreciate near the heart that can create artifacts in the dynamic, the unstable fracture that we cannot see on the static image.
Sappiamo a livello dell'ombosacrale che in clinostatismo abbiamo un carico di 20 kg, in ortostatismo si arriva in condizioni fisiologiche ovviamente a un carico di 100 kg, paziente seduto arriva addirittura a 190 kg. Questo vi fa capire come la posizione che dobbiamo tenere in automobile corretta sarebbe a 90 gradi, cosa che nessuno di noi fa, però indubbiamente sarebbe la posizione che consente di mantenere una corretta postura per evitare appunto i traumi della colonna.
Yeah, here we see what happened to the spine with various weight in the various position.
Sappiamo perfettamente come nella colonna il radiologo è abituato a parlare o di ernie o di fratture, non prende mai in considerazione i muscoli e i legamenti che molto spesso sono la causa dei dolori e la causa di destabilizzazione delle nostre colonne. I muscoli iliopsoas sono importantissimi, allora andiamo a vedere una situazione come questa, al di là della scoliosi che vediamo anche radiograficamente, ma non è tanto la scoliosi quanto la asimmetria dello psoas controlaterale che si ipertrofizza per cercare di compensare la scoliosi. Ma guardiamolo sul piano assiale, guardate quanto è deformato e stirato questo muscolo, il dolore non era una piccola ernia, ma il dolore è questo. Per cui dobbiamo andare a mettere un assetto corretto su questi pazienti.
Yeah, here we don't have to focus on the scoliosis, but it's important to study the ipsos because we can have a clear picture to see that there is an atrophy that is well seen mainly also in the axial picture where you can appreciate that the pain become from the psoas.
Altro caso nel quale era stata sospettata un'ernia del disco, e vedete con il Tesla e mezzo i dischi sono perfetti, in realtà c'era una ptosi del rene destro che riuscivamo a vedere solo nella dinamica in carico, per cui in clinostatismo non era evidente, per cui vedete che il dolore di questa paziente era una ptosi renale e non era certo la causa della colonna. Come abbiamo detto, esami funzionali in clino e in ortostatismo, vedete che in ortostatismo l'ernia, come abbiamo già visto anche stamattina, tende a estrudere a questo livello, ma sicuramente l'importanza della dinamica, soprattutto nei quadri di anterolistesi. Come possiamo dire in un esame statico che un paziente di questo calibro, soprattutto di questo peso, abbia una buona stabilità della colonna quando scende da canestro? Vedete che in dinamica si accentua quasi di 1 centimetro l'anterolistesi, per cui capite l'instabilità importante che si viene a creare.
Yeah, here is very important to see with the anti-rollistasis how it works in the dynamic imaging, because we have an enhancement in this case for this basketball player that we cannot appreciate in the eye field on the
Paziente visto prima dell'intervento, anterolistesi di primo grado di L4 su L5, viene operato, dopo 7-8 mesi dell'intervento torna con dolore alla schiena da presumibile instabilità. In realtà l'indagine anche in ortostatismo ma statica non fa vedere nulla. Vedete che in dinamica dimostra che la stabilizzazione a livello delle 4 e le 5 ha destabilizzato il corpo vertebrale superiore fra le 2 e le 3, per cui come sappiamo oggi il neurochirurgo tende a fare grosse retromarce in questo tipo di interventi.
Yeah, in this case we can appreciate the problem on preoperative, postoperative. They solve the problem, but after they still have pain, and we did the weight bearing, but we cannot see anything that we can see in the dynamic, because when they fix the 2 vertebrae in the lower part, is going to create a dislocation in the upper part. And the same it happens if you do in the upper part, you have a dislocation in the lower part. So.
Altra situazione a livello di colonna in cui i mezzi di sintesi andavano clinicamente il sospetto che andassero a urtare contro le radici, e vedete che nella dinamica, se nella statica c'è solo il sospetto, nella dinamica c'è la dimostrazione perfetta che c'è la compressione diretta sulle radici.
Yeah, here we can really appreciate from the dynamic image how this metal is going to impinge to the nerve roots during the dynamic movement, more than in the static image.
È stato ormai dimostrato ampiamente in tutte le casistiche in campo mondiale come molto spesso la causa di dolore della nostra colonna a livello lombare non siano le ernie, soprattutto se piccole, ma le instabilità delle sacroiliache. Facciamo l'esame in appoggio monopodalico e bipodalico sotto carico e molto spesso vediamo proprio delle insufficienze e delle aperture delle sincondrosi, da insufficienza dei legamenti e da insufficienza dei legamenti iliolombari, che sono alla base della stabilità di queste articolazioni. Sui muscoli rapidamente vedete che un'immagine, sicuramente l'ecografia è la metodica elettiva e la prima che andiamo a fare per lo studio dei muscoli, ma la risonanza magnetica per la sua completezza ci dà dei risultati eccellenti. Questi sono tutti quadri che andiamo a vedere anche con l'aiuto dell'elastografia, che ci dà un grosso vantaggio per la valutazione dell'elasticità dei muscoli, e come vedete questi sono tutti pazienti che vediamo appunto con Porcellini, con Andrea, tutti i pazienti del MotoGP, del Moto2, del Moto3, che molto spesso purtroppo hanno incidenti in cui vengono investiti, per cui giustamente il chirurgo Porcellini mi chiede: dimostra se ce la fai, se il muscolo, pur essendo lesionato in maniera importante, ha ancora una soluzione di continuo, perché se anche poca riesco a fare una ricostruzione plastica e recuperare il paziente.
Yeah, here is very important when we study the muscle to use dynamic examination and together the elastography. And in this case, we can provide important indication for the clinician to see how the muscle is working before to make the surgery.
Ancora nelle sport ernie che oggi sono molto di moda, molto spesso la dinamica sia in ecografia che in risonanza dimostra che in realtà non sono vere e proprie ernie, sono proprio lassità della parete aponeurotica, ma che in dinamica riusciamo a dimostrare e ovviamente evitiamo l'intervento o eventualmente un intervento di rinforzo plastico. Ultime, andiamo rapidi, l'articolazione temporomandibolare, abbiamo dimostrato come sicuramente le immagini con l'alto campo sono più belle, ma dobbiamo fare diagnosi e abbiamo visto che appunto con l'apertura e chiusura nei movimenti di lateralizzazione anche sui piani coronari riusciamo a fare valutazioni che con l'alto campo in indagini statiche non verranno mai fuori. I chirurghi maxillofacciali ci hanno sempre detto com'è che ci date una risposta che è contraria alla clinica, perché in realtà un'articolazione come questa studiata a pazienti in clinostatismo non dà nessun risultato. Invece giustamente in ortostatismo e soprattutto in dinamica, apertura e chiusura della bocca abbiamo dei risultati eccellenti.
So let's move to special cases, and here we can see how dynamics can work very well with temporomandibular joint, and we can see from the study to the dynamic how the menisc can work. So it's really important to see during the dynamic movement what happened.
Ancora, sapete che l'articolazione temporomandibolare, la deglutizione, fonazione e il tratto cervicale sono parenti stretti. Studiamo perfettamente il transito del bolo, con il bolo fatto appositamente, per poter vedere le vie aeree e direi gli otorino sono stati felici di questo, perché molto spesso, soprattutto nel paziente che russa, la lingua occlude completamente le vie aeree a questo punto, per cui loro con l'endoscopio non riescono a vedere quello che sta sotto.
Important case of swallowing.
Altrettanto l'impiego ovviamente in seconda battuta a livello dell'encefalo per i neurochirurghi ci chiedono spesso di fare la dinamica in pseudotumor o tumori veri e propri per vedere appunto se il nervo è ancora libero dalla neoformazione. Anche questa è una valutazione che per loro è molto importante per cercare di evitare di intervenire sul nervo stesso.
And now the special case specific to the ocular optic nerves that is very important for the neurosurgeon for indication before surgery.
Territorio che non è né del chirurgo toracico, né del chirurgo addominale, né dell'aerochirurgo, né dell'ortopedico, e il paziente è già morto, perché parliamo del muscolo diaframma, che forse è il muscolo più importante della respirazione del nostro corpo, è bene andarlo a studiare. Lo studiamo in clinostatismo, in ortostatismo e anche in ribaltamento, come vedete, a circa 60 gradi, ovviamente pazienti selezionati. In questa maniera andiamo a fare delle valutazioni ottimali su tutto ciò che è il comportamento del nostro muscolo, perché in questi casi molto spesso nei motocrossisti che hanno un impatto frequente col manubrio, per cui negli incidenti, lesioni che possono mimare delle lacerazioni delle diaframma destro o sinistro, molto spesso siamo in grado di vedere appunto delle lesioni da compressione del frenico, che è il nervo motore di queste strutture, per cui direi situazioni importanti.
So possibility to study the diaphragm and is the most important muscle of our body, and here we can appreciate a trauma with phrenic nerve paralysis.
Avvertili che siamo quasi in...
Yeah, we are near the end. There will be also a very nice cases. I'm waiting.
Altra situazione, lo utilizziamo nel prolasso del pavimento pelvico nella femmina per vedere appunto prolassi dell'utero, della vescica e del retto, sia sui piani sagittali che assiali che coronali, molto importante per la definizione di un eventuale approccio chirurgico di ricostruzione del pavimento pelvico.
So very important dynamic imaging also in the pelvic floor and mainly in prolapse of the rectum, especially in the female field.
E qui un altro fiore all'occhiello, stiamo collaborando con l'Istituto Meyer di Firenze, che è un'eccellenza in campo mondiale nella ortopedia pediatrica. Facciamo un'infinità di bambini attorno all'anno di vita, 1 anno, 2, 3 anni al massimo, tutti esami che riusciamo a fare senza impiego del contrasto e senza impiego di anestesia, per cui risultati eccellenti, perché giustamente, fra l'altro calcolate che la dinamica fisiologica di un bambino che si muove perché non riusciamo a tenerlo fermo, tante volte ci aiuta in una diagnosi migliore. Guardate questo caso, che è un caso più unico che raro, di doppio scatto dell'anca esterno ed interno, per cui sull'iliopsoas a livello dell'eminenza iliopetinea e sulla congiunzione fra medio gluteo e tensore della fascia lata. E ancora un caso recentissimo che ci ha dato una soddisfazione incredibile, bambino di 1 anno e mezzo che viene inviato dagli ortopedici del Meyer sospettando un'ernia del disco, perché lamenta questo dolore alla schiena, i genitori nel dubbio, il bambino dice la verità, non dice la verità, chiedono l'esame, vedete che un esame statico non dice nulla, nell'esame dinamico la colonna è perfetta, non c'è assolutamente nessuna ernia, ma una situazione clinica che non è così frequente, ma che può essere causa di dolore soprattutto ai muscoli paravertebrali, è il riflesso gastrocorico. Guardate che la distensione delle anse a questo livello nella dinamica, e in realtà è stato dimostrato che la causa era quella. Per cui vedete che conoscendo le problematiche cliniche, andando alla ricerca, si riescono a fare delle diagnosi anche molto raffinate.
Yeah, this is a great case of a patient of 1 year olds, and he had pain on stomach and back pain, but nobody understands why. So as you can see in the static image, the situation seems normal. By the dynamics image, we see a gastrocolic reflex in the intestine, which compress the colon, creating contracture in the muscle of the back, and so therefore create pain to these children. Unbelievable.
Ulteriori studi li facciamo anche con la tomografia computerizzata, col CONBIM, che ci consente di fare ricostruzioni sotto carico, ricostruzioni fatte sempre con gli ingegneri della biomeccanica di Bologna, dell'università, una ricostruzione per vedere appunto un 3D fatto sull'astragolo, ricostruzioni che abbiamo visto già appunto sul 3D in dinamica del ginocchio, per cui direi sono tutte situazioni che oggi la bioingegneria ci propone, soprattutto in che termini? Abbiamo la garanzia con la bioingegneria di avere dei dati matematici di riproducibilità.
So important the collaboration they have with bioengineer in the reconstruction.
Altro direi risultato fantastico, il professor Gasbarini, che è il primo ed è tuttora l'unico al mondo all'Istituto Ortopedico Rizzoli ad aver fatto trapianto di corpo vertebrale in pazienti con lesioni metastatiche. Abbiamo già provato e siamo in grado di poter controllare in dinamica la protesi inserita, per cui per lui è stato un risultato incredibile, perché poter vedere la funzionalità di un intervento di sostituzione protesica a questo livello, direi che lo ha detto lui stesso, è un risultato grandioso.
Yeah, he had a very important collaboration with Dr. Gasbarini, the only one in the world to do transplant in cancer patients. And therefore here we can see the advantage of dynamic image after the transplant, that everything is working well, and for him is very important to know that.
Per finire, questo è uno studio che è stato pubblicato proprio ieri l'altro, quando sono arrivato a New Delhi, con la collaborazione appunto degli ingegneri della biomeccanica. Come vedete stiamo facendo tutti studi matematici di riproduzione e soprattutto che cosa? Un gruppo di ingegneri di Maastricht in Olanda che sta collaborando con noi ha già messo a punto dei device di tutte le articolazioni e anche possibilmente in parte sulla colonna per poter fare esami riproducibili in tutte le situazioni, per cui direi una cosa importante che può essere un vantaggio per tutti noi, e capite che non è il solo uso con il G-scan, ma con qualsiasi risonanza magnetica sarà un approccio importantissimo per poter fare degli esami riproducibili.
So here we are at the conclusion, and Professor Monetti is going to show a scientific paper just published 2 days ago, and is going to underline the collaboration they have with all of these centers and with the bioengineer, showing the advantage that already showed before in dynamic MRI also.
Per concludere, direi che la refrattazione biomeccanica è importantissima, e questa macchina, il G-scan, ci consente di fare, una refrattazione che può essere un tipo di scelta terapeutica non medica o chirurgica, per cui è importantissimo, ma non solo, ma anche, come abbiamo visto, una riflessione d'aspetto medico-legale. E proprio recentemente, in un testo in cui mi hanno fatto fare un capitolo sul GISCAN degli avvocati del Foro di Roma e di Milano, molto importanti, hanno fatto un'affermazione che direi è pesante. In che termini? Hanno detto che una diagnosi mancata in un istituto ortopedico Rizzoli di Bologna, che è il numero uno considerato al mondo dell'ortopedia, ma in tanti istituti ortopedici del mondo non venisse fatta la diagnosi con macchina non idonea, non ovviamente il medico, ma la struttura potrebbe avere delle conseguenze. Per cui direi che è un'affermazione anche per loro di un
Yeah,
certo
so
peso.
yeah, so here it's really important to conclude the biomechanical reporting that can have or a therapeutic approach or a surgical follow-up. And the most important part is also the legal report. And here they did a paper where they put in evidence that if you miss something, you have a legal problem. So it's better to have this.
Ecco, per concludere, innanzitutto chiedi scusa perché li avevamo massacrati, ma direi che era
No,
importante far vedere tutto quello che questa macchina può
yeah.
far vedere e può dare.
Yeah, so,
Però,
sorry for the many slides, but Professor Monetti want to show you the capability of this machine.
ma
In
soprattutto,
all,
essendo probabilmente il responsabile ufficiale delle Olimpiadi nel 2006 nel 2026 a Cortina d'Ampezzo, io propongo che il prossimo nostro congresso della società possa essere fatto alle Olimpiadi. Se
okay.
siete d'accordo siete tutti invitati.
Yeah, so this is a very
Grazie.
great invitation for all of you because Professor Monetti should be the responsible in Winter Olympics in 2026 in Cortina. So if there will be confirmed, he just suggests to make the next meeting all together in the winter season in the ski area in Cortina. Thanks a lot, Professor Monetti. Thanks. Okay, we are at the end. I don't know if you want to make some question. Yes, Dr. Rossi? Yeah? Oh, thanks. Not easy, yeah?
Okay, thank you, Professor Monetti. It's very comprehensive presentation and very complete visualizations. It was very nice and wonderful video.
Devi tradurre?
Sì, ti sta dicendo che sta facendo i complimenti con la presentazione, i video veramente, veramente utili e ti sta facendo i complimenti per una grande presentazione in generale.
Okay, my question is, you show us about when you do the dynamic MRI in ankle. So how can we make an interpretation of the dynamic of the ankle when we analyze the laxity of the ligament?
Allora, chiede la lassità del legamento, che approccio hai sulla caviglia. Perché lei dice è importante la dinamica, però io vorrei capire un po' di più come approcci il discorso lassità del legamento con la dinamica.
Allora direi che puoi dirle che stiamo già facendo appunto dei numeri, delle misurazioni con gli ortopedici, collaboro con tutti gli ortopedici, essendo io nel board dell'ortopedia della caviglia in Italia, stiamo facendo proprio delle valutazioni numeriche e soprattutto, come giustamente la sua domanda è molto interessante, perché non è tanto la lesione del legamento, ma come dice lei la lassità. La lassità la vediamo nei movimenti in un cassetto anteriore, in un cassetto laterale, per cui viene fatto da un'infinità di componenti dell'articolazione in movimento che ti fanno capire cosa succede.
It's a very good question because it's not so important the lesion of the ligament, but the laxity of the ligament, and is doing a study together with some orthopedists because they have to make all measurement for the different laxity, anterior laxity, lateral laxity, etc. So if something is under evaluation to have a final result of measurement, and they should be also make a sort of study to confirm this.
So should we measure something while doing the dynamic? Because in ultrasound we already established that how we diagnose the laxity of the ligament by measure the length of the the ligament itself. So how about from dynamic? Can we just see the qualitatively, or we just also make a quantitative measurement of the ligament as well?
Dice, ma qui possiamo solo fare, sempre sulla lassità della caviglia, delle misure quantitative, oppure possiamo solo vedere la lassità del legamento? Cioè lei vuole sapere più delle...
Possiamo fare delle valutazioni quantitative in un certo qual modo, però calcola, dirle appunto che durante la dinamica ogni paziente ha una lassità capsula legamentosa diversa, no?
Diversa,
È difficile poterlo fare numericamente.
Statistica,
però dille che tutto quello che facciamo lo facciamo in presenza dell'ortopedico che fa le manovre cliniche lui mentre facciamo l'esame.
Okay. So this obviously depends from patient to patient because every patient has different laxity. So what he suggests is that during this kind of examination, he has a lot of indication from the orthopedic surgeon. Sometimes the orthopedic surgeon come to do the movement he needs because it's very specific for patients. So it's something very difficult to standardize.
Okay, so we make a communication with the orthopedic first.
Yes.
What they want to see.
They should tell you how they would like to do this dynamic movement because it depends for each specific patient. It's not something to standardize, not easy.
Okay, thank you.
Ho detto ieri, che ho detto anche adesso, che questa ditta di ingegneri di Maastricht ci stanno fornendo fra pochissimo proprio questi device che potranno fare una valutazione in gradi.
Yeah, they are also working with a Maastricht company that is going to develop some device in order to understand which kind of movement you are doing in the joint. And this is something we would like also to involve as company Esaote for dynamic imaging because can drive in a proper way the dynamic movement with a certain level and with some measurement and degree.
Okay. It's interesting.
That's important.
Yeah.
Yes.
Thank you. Thank you, Prof.
Ultrasound images. And they also had, you were showing about the ultrasound and along with the dynamic images. Don't you think ultrasound is still better off?
A good question. No, ti chiede se praticamente tu hai fatto vedere tante immagini insieme agli ultrasuoni, ma allora gli ultrasuoni sono sempre importanti secondo te? O cioè in queste decisioni?
Domanda interessantissima.
Very interesting question, say Professor Monetti.
Io sono tanti anni che spesso sulla base clinica, è chiaro che non lo puoi fare con tutti, però sulla base clinica preferisco fare prima la risonanza magnetica e poi un'ecografia se vedo che mi dà siamo in quella caviglia specifica. Se io faccio una risonanza magnetica ho un quadro di tutta l'articolazione e vedo. Se capisco che l'ecografia mi può dare qualcosa in più, lo faccio, però sulle articolazioni a mio parere l'ecografia è sempre in seconda battuta, soprattutto su pazienti di un certo peso.
Professor Monetti is going to underline that the first approach is MRI, to have a general evaluation. On the second step is going to do ultrasound to understand the follow-up. But in general, the approach for have a general scenario is the MRI. And
Chi ha inventato, non è una battuta, chi ha inventato l'ecografia dinamica al mondo 40 anni fa è il sottoscritto, perché non è che non ci creda.
Because he trusts a lot in ultrasound. I mean, she started to do dynamic ultrasound 20 or 40? 40 years ago. So this means that it's not that he trusts a lot in ultrasound too, in dynamic, but from his perspective, MRI should be first and ultrasound after, in the follow-up.
You have added elastography along with that.
Yeah.
And how much time does this dynamic MRI take normally?
Sorry.
How long does it take to do the test?
To do
dynamic MRI.
Allora, dynamic MRI, posso rispondere io, mi chiede quanto tempo ci vuole fare la dinamica. But obviously, in terms of sequences, is 1 minute. Very fast. So
sequence you are talking
yeah,
about?
A sequence. The time consuming is related to instruct the patients how to do which movement. And you should also have operator skilled to do that. So it's important that if you want to do dynamic image, you are not going to take a general radiographer and you say, tomorrow you have to do the dynamic image. No. They need to be instructed in a proper way, and Monetti has very good, that's the reason you see this result, because as he said at the beginning of his presentation, it's a collaboration between me, Professor Monetti, radiologist, the clinician, the operator, so all are involved in this anamnesis of the patient and to find the solution. Sì.
Cioè il tecnico è fondamentale, cioè deve avere un'esperienza, una preparazione fondamentale, perché non è la dinamica per fare la dinamica.
Sì, 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 sì.
Sapere cosa fare.
Sì, sì, sì. And thanks to his technicians that are very well prepared, he can be able also to make diagnosis from here by telemedicine, something very difficult. But because he trusts them, he know how to do, how to cut the tendon in the ankle, for example, the Achilles tendon.
So
yes?
we need a training for that.
Yeah. Yeah, yeah. No, this
He
is
was
an
a
important
technician.
part. But
That's what I said.
just to answer to your question, standard examination plus, I would say, 4 minutes dynamic. Because takes 1 minute for the sequence and 3 minutes to understand for the patient how to make the movement. This is the goal.
I wanted, it was astonishing, your representation, Professor, and I wanted to ask you whether if we accompany the dynamic with MR arthrogram, maybe we can overpass the problem of the low field strength of the system, because when we have to see these tiny lesions of scapholunate and also the lesions of the rotator interval that we have micro instability, maybe accompanying this with MR arthrogram, you will have much better results.
I can ask. I didn't see this, but I can ask. Lei chiede praticamente, allora dice che perché per vedere meglio le microinstabilità non faccio anche l'artro.
Yes, but
Are you speaking about arthro injection, okay?
Combining
with dynamic,
Dynamic,
and
yes.
see the liquid inside, yeah.
I wanted to say that
together.
because sometimes we have 3 findings and we don't know which is the most prominent problem. And we have to elucidate which is the problem, the real problem to solve. And sometimes when we can use the MR arthrogram with dynamic to see better these small details that we have, like in coracohumeral ligament.
Like a glenoid lesion,
Yeah.
you mean, but during movement, you do also?
No, we can have previously the injection,
Okay.
we have the arthrogram, and after that, to instruct the patient to have the movement in order to see the details.
Poi la dinamica. Allora, rispondere questo, che teoricamente sulla carta sarebbe forse il top, ma ci sono 2 problemi. Innanzitutto il paziente ti arriva che non sa neanche di poter fare una cosa del genere perché ti direbbe di no lui. Ci sono dei costi maggiori, ma soprattutto che in Italia tu sai che l'artografia, l'ARTO-RM, non è codificata, non è vietata, ma non è codificata. Nel senso che se tu fai del casino, cioè non è codificata. Per cui tu la puoi fare, ma se fai del casino, per cui giustamente non puoi farlo a tutti i pazienti. Cioè
Okay.
Sulla carta sì.
Yeah. Theoretically, yes, but practically, mainly for the Italian rules we have, it's difficult because you cannot do to every patient first, and the second is a risk. It's a risk because it's not on the code of Italian law in the diagnostic field. So if you make some, first of all, the patients don't know that you are going to make all of this procedure, and sometimes it's not easy to make to all patients. And due to the fact that it's not under the code, it's a risk, because if something happens, you have a legal problem. That's the point. This is a rule in Italy. I don't know in the country where you are. I don't know if here from other country we have some experience on that. So it's too complex to see, not too much more.
In Italy, Arthur,
Yeah, in Italy, Arthur RAM is not on the code, so it's not easy. Yes, yes, yes. In this case, we move on deep investigation with high-field MRI with Arthur. I know. You do dynamic, yeah.
Per rispondere a questo, che 90 su 100 non arriviamo a fare l'Arthur-RM perché con la dinamica abbiamo già risolto il problema. Questo è quello che ho detto prima.
And in general, it just suggests me that already with dynamic, in the 90% of cases, it's going to solve the problem. So it doesn't need to make also the contact. Okay, for 10% specific patients, probably you need a deep investigation, and you are right. But for the rest, 90%, 85%, you can already see with dynamic image without Arthur. Okay. Other question? Okay, so thanks a lot. It's been really... Now, before to conclude, it's time to... yeah, just a second. Do you have any question for Andrea Giorgini? You can come here. I mean, he showed something really unbelievable on the shoulder. Do you have any question to his presentation or not?
I have one question.
Okay, Andrea, one question.
Sometimes we have failure of after surgery, even if we have measured the loss, the bone loss in Bankart lesions and Hill-Sachs lesions, we have failure. Do you have experience if your this dynamic procedure helps to answer the question, why do we have failure even if we have done the up-to-date, better, study before the surgery?
Well, the dynamic MRI prevent you to perform the wrong surgery. Because when you have a bipolar lesion on the humeral part and on the glenoid part, it is important to see the dynamic relationship between them. And if you know that the lesion is going to engage, you have to perform for sure a bony recover, so for example a Latarjet or a deny binet. And otherwise, if you see that the engagement is not is gonna you can avoid it, it is better to perform an arthroscopic Bankart repair with probably a remplissage. And yes, definitely this dynamic MRI can prevent the surgery failure.
Okay? Okay, so I think it's also time for Professor Monetti, because it's time to honor you. We are at the end, so I kindly ask, obviously, Professor Majan to come here, and I would like to invite also Professor Villanova, Dr. Bruno, and all the speakers here, because we are at the end, and so I really appreciate to make the award to one of the member of co-founder, member of International Weight Bearing Society, Professor Monetti. Okay, good. So, it's been a very intensive day, I think, but I have seen a lot of interaction, and this makes me very happy because there is more and more interest in this kind of revolutionary application. And I have to tell you, in every meeting there is a growing interest, so that will be an important point. Just information about after meeting. We will have a gala dinner here in the hotel at 7:45, correct? 7:45 p.m. we meet here. Is the restaurant here? Here. So we'll be in the same place. So 7:45 you come back here and please, participant, you collect your certificate of attendance of the meeting. Okay? So, thanks a lot. We hope to announce soon the next Wayberry meeting. I want to make just a special thanks to, obviously, to all the attendees, but mainly to Esaote, Asia Pacific, Rachel Lin, that make this happen. Professor Majan for his warm welcome. We did yesterday also a very warm welcome dinner. And also to Esaote India team, because in my opinion they did a really outstanding work. I've been on 4 edition of Weber MRI and they really surprised me. They worked all night. Unbelievable, and so I want really to thank them. And obviously Diraj that represent all the team, and Chaiwat obviously from Esaote.
Thank you, Giacomo.
Ah, thanks. Thanks to me also. Okay. Oh, thanks. Now I'm in a synergy with Beppe. I can go all in the world with him. Yeah. Okay, thanks.
Don't say too much. He will increase the fees for translation.
This